Okay, so this next module is going to be on an assortment of antimicrobial therapies. So we're going to be discussing concepts about antibiotics. We're going to talk about specific antibiotics and also an assortment of different infections that can occur. Okay, I don't need to say much about this slide, except for the fact that autoclaving is actually a process that hospitals do to sterilize their equipment. So reusable scalpels and forceps and all the hardware that we tend to reuse gets autoclaved. Okay, so this next slide on narrow spectrum versus broad spectrum antibiotics. So just a reminder that antibiotics are only effective for bacterial infections. We do have antiviral medications for certain viral infections, and then of course antifungal infections for fungal infections, and then antiparasitic medications for a number of different parasites that we'll get into. So the concept of narrow spectrum and broad spectrum. So a narrow spectrum antibiotic just means that the antibiotic works on a very narrow list of bacteria. So say for example you have someone with an infection that we just don't know the bacteria yet. So they have a high fever, they're sick, they're coughing, they have a pneumonia, maybe their blood pressure is low because they're septic, and we don't know the exact bacteria yet. Then we would use a broad spectrum antibiotic after we have taken cultures. So we would take cultures, for example, from their sputum, if they were able to produce sputum. We would take cultures from their blood to try and grow the bacteria. So we take cultures from an assortment of places depending on what the specific illness is. After you've taken cultures and you sent them off to be processed, then you would start a patient on a broad spectrum antibiotic, which typically means the antibiotic has a wide coverage for many bacteria that could be potentially causing the illness. So broad spectrum is for wide coverage, and narrow spectrum is typically when you know the specific bacteria, and you don't need a broad spectrum antibiotic. You can narrow in and use the one that's effective for that particular bacteria. Okay, so the next slide on bactericidal versus bacteriostatic. Bactericidal antibiotics kill the bacteria. Bacteriostatic antibiotics stop the functioning of the bacteria, such as stopping protein synthesis within the bacterial cell, and that stops the bacteria from being able to divide. So it just stops bacterial division, and by that way it stops the spreading of bacteria and lets the immune system of the patient destroy the bacteria, compared to bactericidal, which kills the bacteria directly. Okay, so continuing on with the previous slide. So bactericidal antibiotics such as penicillin directly destroy the bacteria, but definitely the immune system is still involved in also killing and getting rid of the pathogen, or the bacteria in this case. On the other side, the bactericidal antibiotics, they they rely more on the immune system because really what they're doing is just preventing the growth of the bacteria by blocking DNA or blocking protein synthesis, and then relying on the immune system to come and destroy the bacteria. The lower part of this slide are two terms: minimal bactericidal concentration of the antibiotic that is required to kill 99.99% of the bacteria in the body or in the infection. So, for example, it'll be studied to see what dose of antibiotic is required to reach the minimum bactericidal concentration in the blood, so that 99.99% of the bacteria is killed, destroyed. On the other side, the minimum inhibitory concentration is the amount of drug that is needed to inhibit bacterial growth from continuing. So they're very similar. One is referring more to bactericidal antibiotics, the MBC, because it's looking at what concentration of this drug in the bloodstream will destroy almost all of the bacteria, the minimum bactericidal concentration. Whereas the other one, what's being studied is the lowest amount of antibiotic, the minimal inhibitory concentration that is required to stop the bacteria from continuing to grow. Okay, and lastly, as a continuation of the above slides, on the bactericidal group, you have, well, beta-lactam antibiotics are really penicillins. Cephalosporins are a very similar group of antibiotics to penicillins. You can almost consider them cousins, and we'll talk about them in a bit. And lastly, another antibiotic that destroys the cell wall is an antibiotic called vancomycin. On the bactericidal group are antibiotics such as the tetracyclines, which are commonly used, sulfonamides, chloramphenicol isn't used very much anymore. We won't use that as a prototype medication. Spectinomycin, that's not used very much anymore. There is another group that we're going to talk to called the macrolides, such as erythromycin, and they also get into the cell, and they're bactericidal. They're bacteriostatic. Okay, so here's another slide just giving some examples of antibiotics that are bacteriostatic and some that are bactericidal. Now, I just want to clarify something. Because something is bactericidal, it doesn't mean that its only action is like penicillin, which is a beta-lactam, by the way, in that penicillins are bactericidal by destroying the cell membrane of the bacteria. There's some antibiotics can get into the cell and block DNA production, block protein synthesis, and still be bactericidal. Okay, and you're seeing some of them here, such as the quinolones is a group that we'll talk about. Or aminoglycosides are another group of antibiotics that inhibit ribosomes within the cells and are bactericidal. They kill the cells. So it's not just only about the cell membrane that makes an antibiotic. bactericidal. Okay, so let's go through a couple of these, and it's really just to get some a bit of comfort with the uh, with the antibiotics. So chloramphenicol, that's an old antibiotic. We really don't use it very much anymore. And the main issue with this antibiotic was that it really had a risk of bone marrow suppression. So inhibiting or harming the bone marrow and causing anemia, low white blood cell counts, and low platelets. So we really don't use it very much anymore. Erythromycin group you're going to hear a lot about because erythromycin is used very commonly in patients that are allergic to penicillin for an assortment of infections. Clindamycin, another antibiotic that really is in its own group, and we'll also go over clindamycin since it's used a lot for an assortment of different infections, and it has some very specific side effects that we'll discuss. Sulfonamides or sulfa antibiotics, very common. They're used for bladder infections, kidney infections. We sometimes use them for skin infections, such as MRSA, methicillin-resistant Staph aureus. So sulfonamides tend to be very effective towards MRSA. And trimethoprim is an antibiotic that's often combined with sulfonamide. So we rarely give trimethoprim by itself. We combine trimethoprim with a sulfonamide to make an antibiotic that actually has two ingredients, the trimethoprim and the sulfonamide. And then the tetracyclines, another very common group. We use tetracyclines very often for acne in adolescents. We can use tetracyclines for pneumonia. So these are all very common antibiotics, except for the first one, chloramphenicol. On the other side, aminoglycosides. These are IV only antibiotics. This particular group. And we don't use them as much anymore because they're quite toxic to the kidney, and they're quite toxic to the ear. And you're going to hear that theme a lot. If something is toxic to the kidney, it's often toxic to the ear. The cells in the ear and the cells in the kidney during embryology, during the growth of the fetus and development of the fetus, had similar cells. So antibiotics that harm the kidneys, or anything really that harm the kidneys, often you'll hear that it has ototoxicity as well. Beta-lactams are referring to penicillins and other antibiotics that have what's called a beta-lactam ring to its structure, such as cephalosporins, which, as I said in the earlier part of another slide, that cephalosporins are really almost like cousins to penicillins. They're very similar to penicillins. And we'll see that there's other beta-lactam antibiotics, and all of them do the same thing. They destroy the cell membrane of the bacteria. Now, next one, vancomycin, is another antibiotic that's usually used intravenously and often for severe infections. And it has very good coverage for Staphylococcus infections, so what we call staph infections. And it's one of the antibiotics that we actually use for methicillin-resistant Staph aureus in a person that's very sick with it. Okay. Vancomycin works like the beta-lactams. It destroys the cell membrane. The quinolones, or another name for it, are the fluoroquinolones. They're a group of antibiotics that we'll talk about, and they actually inhibit DNA within the cell, and they are bactericidal that way. Okay. The next antibiotic, rifampin, you will hear more along uh, the lines of treatment in tuberculosis as opposed to other infections we're going to talk about. So rifampin is really an antibiotic used in the treatment of tuberculosis, and its action really is in inhibiting DNA, and in that way, it's bactericidal. And lastly, metronidazole, another common antibiotic, really alone in its own group. And again, its action is by inhibiting DNA, and you'll see that it has quite a few indications for different um, infections that we'll go through. So I'm not asking you to memorize all these drugs, just so you hear their names and know that some are bacteriostatic and some are bactericidal. And I think when you hear names over and over again, it starts to sink in. So how do we know which antibiotic to use when we're assessing someone with a bacterial infection, or we're seeing a patient that we think has a bacterial infection? Uh, so there are some infections that we just assume are bacterial, such as when someone has a pneumonia. So if a patient comes and they're coughing and high fevers, and we do a chest X-ray and we can see that there's an infiltrate on the chest X-ray, which is an area of fluid um, that's uh, that's uh, that's showing up on the chest X-ray, then we assume that it's a bacterial pneumonia. Now, many pneumonias aren't bacterial. Many pneumonias are viral. But there's no way of distinguishing between a viral pneumonia and a bacterial pneumonia unless you're willing to have a lung biopsy. And we don't do that for pneumonias. We treat them with antibiotics on the assumption that it's possibly a bacterial pneumonia. Okay? So what testing do we do to try and find out which antibiotic is most appropriate for the patient? Well, we take body fluids, right? We take blood, urine, sputum. If there's a wound that's draining a lot of pus, we'll swab it. Sometimes if we're suspecting meningitis, we'll we'll do a lumbar puncture and take fluid that way and send it for examination. Tissue samples, biopsies. So all kinds of an assortment of different ways of getting body fluids or tissues to the lab, and doing what's called a culture and sensitivity on the fluid. So what do? They just put it on a dish of growth medium and see if a bacteria grows on the dish. So this can take days. I mean, a CNS can take 2 or 3 days before you get a result. So the culture part is saying which antibiotic grew on the culture disc, and the sensitivity part is a list of antibiotics that you receive, that which antibiotics is this particular bacteria sensitive to. And it lists usually anywhere from 5 to 10 antibiotics that this particular bacteria is sensitive to, and you use one of them. Now, At the beginning, you don't have your culture and sensitivity report. So you have to base your antibiotic choice on which infections are most likely causing the particular condition. So whether it's a throat infection, a pneumonia, a bladder infection, a kidney infection, there's certain bacteria that are much more commonly associated with each particular condition. So we will use an antibiotic empirically, meaning empiric therapy means we're going to treat you prior to really knowing which bacteria it is. So what's a gram stain? So a gram stain is much, much faster. We can get a gram stain back much faster than it takes uh, a bacteria to grow on a culture medium. Because all we need to do is send the sample to the lab, and the lab technician will stain the fluid or the tissue sample, and see if it holds the stain that's applied to the liquid or the tissue. And this divides bacteria very quickly into gram-positive bacteria or gram-negative bacteria based on whether they turn purple, gram-positive, or gram-negative, they turn pink. They don't tend to hold the dye as well, gram-negative bacteria. And this can really help because we know that certain bacteria are gram-positive, such as Staphylococcus, Streptococcus. We know that some bacteria are gram-negative, such as E. coli, Klebsiella. So it really helps in a very, very fast way to determine, oh, I have a gram-positive bacteria. They tend to be more sensitive to this group of antibiotics. That's what I'm going to use. Because remember, the culture and sensitivity can take 2 to 3 days. And sometimes once we get a culture and sensitivity back, we need to change the antibiotic because the antibiotic that we started them on, the bacteria isn't sensitive to that particular antibiotic and we need to switch it. So gram stain is a very quick and fast way of getting the division of gram-positive or gram-negative bacteria, and can really quickly help on the same day, if you really want a gram stain, to choose which antibiotic to use. And the pictures that are being shown on here is really what we do with a throat swab. So we'll take a throat swab, we'll send it off to the lab, they'll put it on a culture medium and see if it grows Streptococcus A bacteria, Strep A bacteria. And if it does, then often we'll treat with an antibiotic to clear the strep pharyngitis. Okay, and here's just an image of gram-positive staining and gram-negative bacterial staining. And you can see that gram-positive bacteria, which tend to have a thicker cell membrane and more peptidoglycans on the cell membrane, they hold the stain much, much darker compared to gram-negative bacteria, which have a thinner cell membrane and don't hold the stain as well. So this really splits it up into two groups and can be really, really helpful in deciding which antibiotic to choose, just based on whether they're gram-positive or gram-negative, long before you get a culture and sensitivity back from the lab. So we've spoken about this in an earlier slide. So just the culture and sensitivity. So disc diffusion test. So the sample is basically just placed on several discs that have different antibiotics within the media on the discs, and to see if the bacteria are sensitive to the antibiotic that's in the disc. And if bacteria doesn't grow, then it's a sensitive antibiotic. If bacteria thrives despite a certain antibiotic being like on the disc, then it's not a sensitive antibiotic. And then what can be done is what's called a serial dilution, meaning, okay, I know that this antibiotic is sensitive to kill or stop the growth of a certain bacteria. What's the lowest amount of concentration I need of the antibiotic to destroy the bacteria? So that's the minimum inhibitory concentration that we spoke about. So they can dilute the discs more and more and more to get to the lowest concentration required in the blood that will destroy the bacteria. And the same goes for the minimum bactericidal concentration. How much of the antibiotic do I need that's going to destroy the vast majority, 99.9% of the bacteria? Okay, we discussed those concepts before. So, and then you get a readout a few days later of the culture report. Sometimes it just says no growth, or sometimes it'll tell you the exact bacteria and exactly which antibiotics the bacteria are sensitive and resistant to. Okay, and this is exactly what the discs look like for culture and sensitivity testing. Right? They've just put little samples of the fluid collection, whether it's urine or blood, onto a disc that has growth medium in it to encourage the bacteria to grow. And some of the discs may then have antibiotics within the growth medium to see if it stops the bacterial growth, meaning it's sensitive to the antibiotic. So here are just some host factors to consider with infections. And we're really talking along the lines of bacterial infections still, which really are the ones that we're often most involved with. Identifying a patient with a bacterial infection that can be responsive to a particular antibiotic. So the immune system is, the antibiotic gets lots of credit, but it's the immune system that is often the main factor that fights a bacterial infection. The antibiotics can definitely help in destroying the bacteria or stopping the growth of bacteria, but the immune system is really critical to clear the bacteria. Certain locations of infections, antibiotics can have a really hard time getting to. So, for example, within the brain, some antibiotics don't cross the blood-brain barrier very well. They don't get to high concentrations within the brain. So that can be a barrier to treating meningitis, for example. Abscesses are basically pockets of infection, pockets of pus. For example, you could have a skin abscess. You can have deep abscesses in your, beneath your skin, in the subcutaneous tissue that antibiotics can't get to because there's no blood supply to pockets of pus, right? So abscesses need to be drained. And sometimes they need antibiotics once they're drained, but without draining them, the antibiotics really can't get to a pocket of pus, an abscess. Foreign bodies that are stuck in the body. The antibiotics have a very difficult time treating and clearing an infection if there's still a foreign body left in the body. For example, you have a huge splinter at the bottom of your foot. Without removing the splinter, and your foot's become infected, without removing the splinter, the antibiotic is not going to clear the infection. So the treatment is really removal of the foreign body plus antibiotics for the infection that's developed. The age of the person. So a very, very young infant, a neonate, or a very, very old person, they have higher toxicities to drugs, but even more important, they have an immature immune system. So newborns have a very immature immune system, and they as well have not received any immunizations yet. So they're very dependent on maternal antibodies. So antibodies that were given through the placenta from the mother that circulate for the first weeks to months within the newborn until their immune system starts to develop. An older person, the immune system has just gradually weakened over the years. So older people are much more prone to serious bacterial infections because of a gradually weakening immune system. Pregnancy, well, pregnancy, because there's a risk to not only the mother, but also to the developing fetus of the infection, but also of the antibiotics that are required to treat the infection. So if you have a kidney infection in the mother, antibiotics that are required to treat the kidney infection will likely circulate through the placenta and into the fetus. So there's potential harm to the fetus because you're having to treat the mother's kidney infection. Okay? Lactation, the same thing. If the mother requires an antibiotic, likely some of the antibiotic will get into the breast milk and potentially cause side effects to the infant. And then there's allergies to antibiotics. Some patients have a lot of allergies, which can make it difficult when choosing an antibiotic, since the group of antibiotics that tend to be used most commonly for a particular infection can't be used, say due to an allergy, and you have to go to, say, a second choice or a third choice antibiotic. So let's start talking about antibiotics that affect the bacterial cell wall. And when we're talking about affecting the bacterial cell wall, by far the biggest group is going to be the penicillins and the cephalosporins, which, remember, are cousins of the penicillins. They're very similar. They both have a beta-lactam ring, along with some other antibiotics that have a beta-lactam ring, and they're all called as a group beta-lactam antibiotics. So when we're talking about antibiotic therapy, what are we looking for? So really what we're looking for, let me give you an example. So a patient comes in with an area on his leg that is red, tender, warm, and swollen. And it happened after he cut his leg 5 days earlier. So he has what's called cellulitis, which is typically a bacterial infection from Staphylococcus or Streptococcus, since that is typically what enters the skin wound when it's cut. So when we start an antibiotic, what we're really looking for is a therapeutic response. So when we talk to the patient about the expectation of improvement in the next 2 to 3 days, since antibiotics take usually around 48 hours to start being effective. It may be a bit earlier, but typically it's a few days. And the response that we're looking for is decreased tenderness, decreased swelling, decreased redness, and decreased warmth, meaning really that the bacteria are being destroyed and the inflammatory cycle is settling down. So we're looking for a reduction in the signs and symptoms of infection, and also the systemic signs of infection, such as fever, chills, aches, rigors, which is the shakes, and potentially, if we do a blood test, we're looking for an improvement in the white blood cell count. So if it was elevated initially, we'd be looking for the white blood cell count to be normalizing, to be returning back to a normal baseline. So, so it's very important to understand what's being treated, but also what's the expectation, what's the therapeutic response that's expected, so that you can tell the patient, this is what we expect to happen in the coming days with this antibiotic therapy. Okay, so methods of antimicrobial and antibiotic actions. So we've spoken about destroying the cell wall of the bacteria, and preferably not the mammal, not the human. So these are typically bactericidal antibiotics. Inhibiting the conversion of an enzyme that's very important in the bacteria's survival is another mechanism that can be used. Or impairing the protein synthesis in the bacteria by inhibiting, say, the ribosomes. And that's going to really slow down the bacterial division. And lastly, inhibiting the DNA or the RNA of the bacteria so that it can't divide. And remember, some of these antibiotics are bacteriostatic and some of them are bactericidal. But typically, the ones that destroy the cell wall are bactericidal. Okay, so antibiotics affecting the bacteria cell wall. So penicillin and cephalosporins are the most common groups for sure that we use on a regular basis, whether orally or intravenously, for an assortment of infections. The carbapenems and the monobactams are used typically for much more severe infections and in-hospital infections. So they're definitely not as commonly used. And all of the effect of these antibiotics, the beta-lactam antibiotics, which we're talking about right now, is destruction of the cell wall. And the drugs that we're going to be talking about are mainly going to fall into the beta-lactams that are either penicillins or cephalosporins. Okay, so remember the ending of especially if we've underlined them. Just remember the ending. Sporin for cephalosporins, cillin for penicillins. So this slide is not meant to scare you. You do not need to know this entire list of penicillins and cephalosporins, but let's just talk about it a bit because it'll just make a bit more sense in terms of where these all fit. So these are all beta-lactam rings, right? They all have in their structure beta-lactam rings. So we would call them beta-lactams. So it's the penicillins with that long list that we'll talk about a couple of them, but notice they all end in cillin. the cephalosporins, of which there's multiple generations, first generation, second generation, third generation, and so on. And then the carbapenems and the monobactams. Okay, so those are all the beta-lactam rings. And as I said, we're not going to spend a lot of time talking about carbapenems or monobactams, mainly because they're just not used as commonly. But we will spend more time talking about penicillins and cephalosporins. Now, just one point here to talk about, since why are there so many penicillins? Well, they all have slightly different spectrum of activity against bacteria. Okay, so and you won't be expected to know the spectrum of activity of all these antibiotics. It's just not possible. Okay, and the cephalosporins. Why were all these cephalosporins made? Well, it's the same reason, just the spectrum of activity towards certain bacteria. So, as an example, first generation cephalosporins tend to be very effective against gram-positive bacteria, such as Staphylococcus and Streptococcus. And as the generations go further and further on, third generation, fourth generation, and so on, they become much more effective against gram-negative bacteria and less effective against gram-positive. So that's just give you an idea of why they're listed in generations, is that first generation much more effective against gram-positive, and then further down the generations much more effective against gram-negative bacteria. Now, if you look at the top right corner, you'll see that we have beta-lactamase inhibitors. Okay, clavulanic acid, sulbactam, and tazobactam. What are those chemicals? Well, the penicillins, the bacteria started to get very smart against the beta-lactam ring. And some bacteria started to produce beta-lactamase, meaning the bacteria would produce and secrete an enzyme that could destroy the beta-lactam ring, and then make the antibiotic ineffective. So by adding a beta-lactamase inhibitor to one of the penicillins, you could stop the enzyme that's being secreted by the bacteria from being effective. So these beta-lactamase inhibitors are added to some antibiotics, and we'll talk about some, and when the bacteria secretes beta-lactamase, well, the antibiotic has a beta-lactamase inhibitor within it to stop it from being effective, so that the antibiotic portion can still work against the antibiotic. Okay? And there's antibiotics that have these beta-lactamase inhibitors added to them, just for that reason. What about combination antibiotic therapy? So combination antibiotic therapy is often used when patients are very ill. Remember, at the beginning, when someone comes in very sick with a bacterial infection, we don't necessarily know which bacteria is causing their sepsis or their serious bacterial infection. So sometimes we have to combine antibiotics, which can be helpful since we're covering more of the spectrum of potential bacterial offenders. At the same time, we have to accept the fact that we can expect more adverse effects, more cost, more toxicity, and the potential for developing resistance um, or resistant bacteria that that are now growing. Okay, so let's look at a prototype penicillin here. So penicillin G, which is typically an IV or an IM, an intramuscular or an intravenous penicillin. And the oral equivalent would be penicillin V. And these are commonly used, especially the oral form, the penicillin V, for strep throat or prophylaxis to a dental procedure that you're going to have if you have a valvular disease, or any gram-positive bacteria are typically sensitive to penicillin G, okay, or penicillin V. Okay, so penicillin V is often given for strep throat as long as you have no allergies to penicillin. How does it work? Inhibits the cell wall synthesis. Definitely a narrow spectrum antibiotic. It it doesn't cover many types of bacteria. So you can see under indications, it's basically gram-positive cocci, and we have quite a few other antibiotics if we wanted to make our spectrum broader. Adverse effects, really just some gastrointestinal symptoms, some diarrhea, potentially some vomiting. Thrush is a common side effect to really any antibiotic. So oral thrush, which is the white yeast infection in patients' throats, or you can also get a yeast. Women can get a vaginal yeast infection, so vaginal candidiasis, and they can both occur from antibiotics. What are the contraindications? So definitely a prior allergic reaction to penicillin would be a contraindication. And because penicillins are excreted by the kidneys, if you have severe renal disease, it would have to be quite severe not to be able to take penicillin. But severe renal disease would be a contraindication since you're just not able to excrete the penicillin. So as I said, these are so Pen G, intramuscular or intravenous. Pen V is oral. Always consider allergies before giving a penicillin type antibiotic. And if it's the first time that they've received it, sometimes we'll monitor them, especially if it's an inpatient setting. We'll just monitor them since it's their initial contact with the penicillin. You usually take penicillin with meals, and always advise the patient to complete the full course of the antibiotic. In women of childbearing age, we can recommend them to take a second form of birth control pill or birth control therapy, since if they're on the birth control pill, there is a theoretic risk that the antibiotic can reduce the effectiveness of the birth control pill, making it ineffective. Okay, so amoxicillin, another type of penicillin. So if you had a penicillin allergy, um, especially a severe penicillin allergy, you definitely wouldn't use amoxicillin. Amoxicillin is given orally. It comes in capsules. It comes in liquid suspensions for children. We use it all the time for respiratory infections such as pneumonia, sinusitis, ear infections in children or adults. We can sometimes use it in more serious conditions such as endocarditis, which is an infection of the valves of the heart. Typically, if someone had an infection of the valves of the heart, we would be using intravenous antibiotics. And again, we can use this as a prophylaxis prior to a dental procedure if you need to take an antibiotic due to a valvular problem. It blocks the synthesis of the bacterial cell wall, just like all penicillins do, or all beta-lactam rings do. And the adverse effects will be very similar to Pen-G. The contraindications, an allergy to penicillin, and likely the most common adverse effect would be a rash, maybe some loose stools. That would be the most common side effect to amoxicillin. So just monitoring for a rash, monitoring for any signs of anaphylaxis, which is a rash combined with either a respiratory issue or an airway issue or a cardiovascular issue or a gastrointestinal issue. So someone takes a pill such as amoxicillin, they get an urticarial rash, they get swollen lips, swollen tongue, or wheezing, or low blood pressure, or they're vomiting violently after taking the pill, plus an urticarial rash. That would be considered anaphylaxis. Diarrhea, not an uncommon side effect or adverse effect to amoxicillin. There is one particular diarrhea that any antibiotic can cause, and that's a bacteria called Clostridium difficile. And basically what happens is the antibiotic kills off the healthy, good bacteria in your colon, and Clostridium difficile can grow and flourish instead, leading to a severe diarrheal illness from the Clostridium difficile infection. And typically it's really foul smelling diarrhea with abdominal cramps, fevers, and this secondary infection from taking the amoxicillin needs to be treated in its own way, and we'll talk about that. The other thing to consider is amoxicillin is often given for strep throat. And strep throat can look very, very similar to mono. It's a red throat. Often you have white plaques at the back of your throat. You can have swollen lymph nodes in your neck. So it can look very similar. And if you treat someone with what you think is a strep throat, but it ends up being mononucleosis, which is a viral infection, giving them amoxil in combination with mono almost guarantees them to get a diffuse body rash from the amoxicillin. So it's something about the viral infection of mono that you actually don't need an antibiotic for. But since they were given amoxicillin, they can get a diffuse body rash from that particular combination, that interaction. Okay, so let's look at ways or a way to combat antibiotic resistance that occurs in bacteria. So we know that bacteria will become resistant to antibiotics if bacteria see similar antibiotics over and over again. So inappropriate prescriptions of antibiotics for, say, a viral infection, which we don't use antibiotics, will create antibiotic-resistant bacteria in the population. Okay, so we're trying to be
much more selective in who gets an antibiotic and who doesn't require an antibiotic. Okay, so let's look at this slide, combating antibiotic resistance. So bacteria can produce an enzyme called beta-lactamase. And beta-lactamase is actually the ring, or beta-lactam is the ring of penicillin. So if bacteria can produce an enzyme called beta-lactamase, they can destroy penicillin type antibiotics, such as, well, all penicillins. Cephalosporins are very similar to penicillins. They're kind of like a cousin. And then the other ones that are less frequently used, except in the ICU, monobactams, carbapenems. So as long as you just know that there's a bacteria called beta-lactamase that can destroy the penicillin ring, the beta-lactam ring, okay? And when that happens, that means that basically penicillins are not effective to destroy this particular bacteria, okay, because of the enzyme they can produce. So in order to combat that, we can add a structure or a chemical to the penicillin that's going to block the beta-lactamase produced by the bacteria. And these are called beta-lactamase inhibitors, or beta-lactam inhibitors. So one of them is clavulanic acid. So if you look at the bottom, what is augmentin? Well, it's just amoxicillin, which is a penicillin, plus the clavulanic acid. Okay, and what does the clavulanic acid do? Well, when it gets into the bloodstream and gets to the bacteria, it actually is able to block the enzyme beta-lactamase so that it doesn't destroy the amoxicillin. Okay, so you can add chemicals to antibiotics such as clavulanic acid, or that blocks the enzyme being produced by the bacteria. So it's this constant back and forth between finding out what the bacteria can produce and then coming up with a chemical that can block it. And that's why there's a constant fight between antibiotics and bacteria. And we're always trying to stay ahead of resistant bacteria. And this is one way to do it, by inhibiting the beta-lactamase enzyme that are produced by certain bacteria that destroy the penicillin ring.
Okay, so ampicillin, often used IV. It does come orally, but we have amoxicillin orally, so ampicillin is often used intravenously. And again, it can be used for ear infections and sinusitis and respiratory infection, genitourinary infections, meaning bladder infections, which is called cystitis, or a kidney infection, which is called pyelonephritis, or even meningitis. Ampicillin is often part of the treatment of meningitis. So it's definitely bactericidal, like all beta lactams. It has a broader spectrum, meaning it covers more bacteria than penicillins. It has really the same adverse effects: rash, diarrhea, anaphylaxis, superinfections, meaning you got a secondary thrush infection in your mouth, or you got a secondary vaginal yeast infection, or you developed Clostridium difficile from taking the ampicillin. Those are super infections. They occurred because of the use of the antibiotic. Nursing care, definitely instructing patients on the signs of secondary superinfections because of the antibiotic use. The furry overgrowth on the tongue being thrush, vaginal itching and white discharge, which can be a yeast vaginitis, or loose, foul-smelling stools, which is Clostridium difficile, which really, that is what it is. It's foul-smelling stools. It's really unmistakable when you smell it for the first time.
Okay, so here's a nice slide on cephalosporins. And I mentioned before that cephalosporins are very similar in structure to penicillin. They have a beta-lactam ring. Okay? They just have slightly different structures that are coming off of the ring, different molecules. So we call them cephalosporin antibiotics. Okay? And over time, there's been developed 4, and I think actually now 5 generations of cephalosporins. And so depending on what generation the cephalosporin is in, will kind of help determine what we use it for. Okay, so let me give you an example. The first generation cephalosporins, such as cefazolin that you'll see on the right image there, or cephalexin, they have a lot of what we call gram-positive coverage, meaning they can destroy gram-positive bacteria very effectively. Okay, what are gram-positive bacteria? Well, how about Staphylococcus or Streptococcus? Where have you heard of Streptococcus? Well, how about strep throat? So, for example, cephalexin, which is Keflex, could be used to treat strep throat. Where else do we find Staphylococcus and Streptococcus bacteria? Skin infections. And one of the most common uses of cephalexin, which is oral Keflex, or cefazolin, which is intravenous Ancef, are skin infections. Okay? And that's why when you see someone being treated for, say, cellulitis, which is a bacterial infection of the skin, invariably they're getting cephalexin or cefazolin, depending on how bad the cellulitis is. As you go down the generations, the cephalosporins become antibiotics that have much better gram-negative coverage. Okay, so so what does that mean? Well, gram-negative coverage is bacteria that stain gram-negatively. And where do we find those bacteria? Well, how about urine infections? Okay, Klebsiella, E. coli. They're gram-negatives, and they respond very well to cephalosporins as well. So we could use some of these cephalosporins for urinary tract infections. In the lungs. In the lungs, you can have gram-positive bacteria, you can have gram-negative bacteria. So some of these cephalosporins can be used for pneumonias, respiratory conditions, sinus infections. Okay, so we choose the cephalosporins based on what we think the most likely bacterial infection is. Is it gram-positive? Is it gram-negative? We wait for our cultures to return, and we can start one of these antibiotics based on what we think the most likely bacteria is causing the infection. Now, I wouldn't get too overwhelmed with all the names here, okay? Notice they all start in CEPH, CEF, right? So cephalexin, cefazolin, cefuroxime, cefaclor. So I don't think I would try and tease out all of the indications for every antibiotic. That's too much, right? I would just get the idea of what we were talking about in terms of first generation, more for gram-positive infection, bacterial infections, fourth generation or fifth generation, more for gram-negative. So just get the concept of that. Okay?
Okay, so this next prototype medication, cephalexin, is a cephalosporin. This one's actually a first generation cephalosporin. Remember, we spoke about different generations of cephalosporins, and why do we have these different generations? Well, the ones that are closer to a first generation cephalosporin tend to cover more gram-positive bacteria, and the ones that are further down, such as fourth or fifth generation, tend to have better coverage for gram-negative bacteria. So cephalexin, if there's one indication that I would remember for this particular antibiotic, it's skin infections. We use it all the time for different types of skin infections, whether it's cellulitis, which is an expanding red bacterial infection just below the skin, or impetigo that children get, which are blotchy patches of crusty infection, crusty bacterial infection on the skin. So these work the same as penicillin. They destroy the cell wall. So, and I mentioned before, they're very close to penicillin in terms of similarity. They have a beta-lactam ring, um, and uh, there is some potential for cross-reactivity. If you're very allergic to a penicillin, meaning you have anaphylaxis, we wouldn't use a cephalosporin. If you have a mild allergy, such as a rash to a penicillin, we can still use a cephalosporin. So the main adverse effects, again, to most antibiotics, some nausea, some vomiting, and some diarrhea. Superinfection, meaning a yeast infection, potentially a vaginal infection, the potential for Clostridium difficile. Uh, some antibiotics are more common to cause this than others. Cephalexin would not be a common one to cause a superinfection, but it's still possible. Contraindications, a severe allergy to penicillin or cephalosporins. And just like with all penicillins, if a patient has a renal impairment, they're not going to excrete it as easily. So we have to be careful giving full doses of penicillins or cephalosporins if someone has renal failure. This one is not a problem taking with medications at all. Remember that prior to giving an antibiotic, if there's an area that a sampling of blood, urine, or tissue needs to be taken to be sent to the lab, that needs to be done before the first dose of the antibiotic. Otherwise, there's a good chance nothing will grow when sent to the lab, since the bacteria has seen an antibiotic already. Monitoring of bowel function, well, that's just, report back if you get terrible diarrhea from this antibiotic. Now, in the ATI book, I'm just reviewing a couple of concepts here, and I want to just add it to this slide. So, under first generation, in the ATI book, they mentioned cefazolin. That's an intramuscular or intravenous first generation cephalosporin. We use that really for similar reasons as oral cephalexin. So a severe skin infection. So this one's oral, cephalexin. Cefazolin is intramuscular or IV. The next one that I just want to mention is ceftriaxone. And this is a third generation cephalosporin. We use it all the time as an IV antibiotic for pneumonia or for sepsis, or we can use it as an intramuscular injection uh, for a sexually transmitted disease such as gonorrhea. It covers gonorrhea very well. This particular antibiotic, ceftriaxone, is a fantastic antibiotic. You just can't give a lot of it intramuscularly because it really stings. In fact, sometimes what the nurses will do is dilute it a bit with an anesthetic, such as lidocaine, and inject it together, just to take away a bit of that stinging pain that it causes. Now, most of the cephalosporins do not cause any bleeding tendencies. I can see that it's listed uh, with a few in the book, but in general, they do not cause any bleeding tendencies. They can cause some phlebitis at the site of where they're being given intravenously, and that's why we tend to just give them slower. We don't give them as an intravenous bolus, like a straight push into the vein. So with any of the cephalosporins, um, they can be used with a mild penicillin allergy. With a severe penicillin allergy, we would avoid any of the cephalosporins because of the potential of cross-reactivity, meaning anaphylaxis to penicillin, we won't take the chance with a cephalosporin because they have a beta-lactam ring, so they're a bit similar. Now you're going to see a medication listed called probenecid. So this particular drug we can use to stop the excretion of whether it's a penicillin or a cephalosporin. We can hold it in the body for longer if we give someone a dose of probenecid. And that can be useful in certain antibiotics. So some of these cephalosporins and penicillins are dosed 2-3 times a day. So if we give an injection of probenecid before the dosing, we only need to give it once a day because the probenecid stops the excretion by the kidney of the antibiotic. So probenecid can be very useful if somebody's going home with an IV dose of an antibiotic or a penicillin or cephalosporin, because they would only need it once a day when they're given the injection of probenecid first. Okay, so meropenem. We'll talk about this a bit. This is an in-hospital type antibiotic. So it's a beta-lactam. So it's in the same category as the penicillins, but it's really used for severe bacterial infections. So we would consider using this particular antibiotic in someone with a severe pneumonia, someone with peritonitis, which is bacteria in the peritoneal cavity surrounding the bowel. So in someone, say, with a perforated bowel or a perforated ulcer, a severe urinary tract infection, um, so a kidney infection, which is called pyelonephritis, which is then spilling bacteria into the bloodstream, causing sepsis. We could use meropenem. And you're going to see that a lot of the adverse effects are going to be similar to a penicillin. It's going to be used with care in someone with a renal insufficiency or renal failure. It can cause superinfections, just like any other antibiotic. Gastrointestinal upset, we've spoken about with other antibiotics. And of course, not to use with a severe penicillin allergy. Okay, so I'm finished with meropenem, but I just want to add a bit more information to some of these slides, not necessarily about meropenem though. When we go back, I saw in the ATI book that with the penicillins, it's mentioned that they can cause hyperkalemia, dysrhythmias, hypernatremia, uh, and I just want to mention. I just want to go back to that just so I can mention this to you. This would be a very uncommon complication and would usually be for someone who's on IV penicillin G for an extended period of time. So why is that the case? Well, penicillin G, the solution it comes in, has potassium. So it's not the penicillin G, it's just that it has a solution with potassium in it that can cause high potassium in the bloodstream. There's another one that tends to have more sodium. So ticarcillin, that's an IV penicillin. That comes in a solution since it's IV with that can be high in sodium, so it can cause hypernatremia. I just didn't want you to think that it was the actual penicillin itself. Okay, so aztreonam. I think just recognizing this antibiotic as a antibiotic that has a beta-lactam ring, so it's associated with penicillins. It's used for severe infections. Again, just like meropenem, it's an intravenous or intramuscular drug. You're not going home with this medication. This would be an in-hospital drug for severe kidney infections, sepsis, severe pneumonias. It works the same as penicillin, gives the same side effects. We would be careful in someone with kidney failure in particular. So just I think recognizing this drug as an ICU type drug for someone who's very ill with a bacterial infection. Vancomycin is the next antibiotic we're going to talk about. A relatively common antibiotic. We use it for MRSA infections, methicillin-resistant Staphylococcus aureus. So these can be, this particular bacteria can cause deep infections such as a pneumonia. It can cause sepsis. It can cause skin infections. So it can cause a variety of different types of infections. Remember, some patients actually are colonized with MRSA, especially in their nose. And they can pass this on from person to person. So if you've heard of entire football teams or entire soccer teams becoming infected with MRSA, it's usually because someone was colonized, and just by sharing of equipment, other members of the team have become infected with this particular bacteria. That's why, for example, on wrestling teams, you'll hear that if someone has a rash, they can't go to a wrestling competition. They need to be cleared of having a bacterial infection such as MRSA on their skin. Okay, so vancomycin can be used for MRSA infections, and they're not just skin infections. They can be pneumonia, and they can be sepsis. The other indication is to treat Clostridium difficile colitis, which is usually caused by an antibiotic in the first place. So a patient received a different antibiotic and then came back with severe diarrhea, cramping, bloody stools, and when we did a culture of the stools, we realized that they have Clostridium difficile. And vancomycin orally is used for this particular condition. In fact, it's become the #1 drug to use for Clostridium difficile colitis. So the difference with the oral versus the intravenous is the intravenous antibiotic form uh, is not absorbed by the gastrointestinal tract. It stays in the gastrointestinal tract. So that's why vancomycin, not only is it effective for Clostridium difficile, but it actually doesn't go into the bloodstream when given orally. It stays in the gastrointestinal tract. So the IV form of vancomycin would be more reserved for severe Staphylococcus aureus infections. Okay, so let's go on a bit here. Under actions, very similar to the penicillin, although remember, this is not a penicillin at all. It can lead to phlebitis when it's given intravenously, which is redness, pain, and inflammation of the vein where the antibiotic was given. Some drugs are much more notorious to cause phlebitis than others. Vancomycin would definitely be one that can irritate the vein. And it can lead to a syndrome called red man syndrome that we'll come back to. Under nursing considerations, so remember, orally, it stays in the gastrointestinal tract. So why would we use it? Only for Clostridium difficile in the gastrointestinal tract, since that's where it's causing the problem. Intravenously, for more severe Staphylococcus aureus infections. We do need to do peak and trough levels every 3rd dose of the antibiotic. So we do serum levels of vancomycin, because one of the concerning adverse effects of vancomycin is nephrotoxicity and ototoxicity. So we really want to follow the dose to make sure that we're not getting beyond the therapeutic level of vancomycin. And you can see here that it's given over 60 minutes to avoid that phlebitis. So BUN and creatinine are kidney function markers in the bloodstream. So they will be checked on a regular basis if you're on vancomycin, plus the peak and trough levels to make sure that it's in the therapeutic window. Okay, so this next slide is just giving you the signs and symptoms of red man syndrome, which is typically occurring due to a fast infusion of vancomycin, and intravenously, by the way, not orally. So what can it lead to? Well, fever, chills, low blood pressure. You can get this diffuse red rash on your body, itching of the rash, some muscle weakness, dizziness. So this is from a rapid infusion of vancomycin. So just remember, red man syndrome is from a fast infusion of intravenous vancomycin. And this is really the main reason, well, including the phlebitis, why it's infused over 60 minutes. Okay, so this slide is showing you the rash of red man syndrome from vancomycin intravenously. And it's typically an itchy rash, diffuse all over the body, and most often occurs because of the infusion rate of the vancomycin. It can still occur even if the vancomycin has been given over an hour. So what to do with this particular reaction? Well, stopping the vancomycin and definitely checking vital signs is a good idea. Giving diphenhydramine as an antihistamine to treat the itchy rash. And then consideration can be given to restarting the vancomycin at a slower infusion rate. So this particular rash is not an allergic rash. It is caused by the vancomycin and how rapidly the vancomycin was infused, but it's not based on an allergy. So the mechanism is that vancomycin, when given at a rapid infusion, can cause significant histamine release from the mast cells and lead to this rash, lead to the itching, cause hypotension since histamine vasodilates the blood vessels, but not directly based on an allergy. Okay, so phosphomycin, this one will be relatively straightforward. We use it for urinary infections, so bladder infections. This antibiotic also inhibits the bacterial wall synthesis. Similar side effects to some of the other antibiotics we've seen in this group or in this category of bacterial wall inhibitors. Diarrhea, headache, vaginitis, that's usually yeast vaginitis. It's taken on an empty stomach, and it's very simple. It's a single dose for a bladder infection. And really, that's the main reason that we use this antibiotic. So typically, someone will come in with symptoms of cystitis, such as painful urination, the urge to urinate, maybe they're bleeding a bit in the urine, hematuria, and instead of taking an antibiotic for 5 days or 7 days, phosphomycin can be given as a 1-day treatment for the cystitis. More expensive than other antibiotics that are given over the span of 5 to 7 days. Okay, so we're going to move away from antibiotics that impact and destroy the cell wall of the bacteria, such as the penicillins, the cephalosporins, vancomycin, phosphomycin, and we're going to concentrate on some antibiotics that affect the bacterial protein synthesis, and in that way stop the bacteria from dividing and can also destroy the bacteria. So remember, some of these antibiotics can still be bactericidal, and some of them will be bacteriostatic. So this slide is just a reminder of the concept of bactericidal and bacteriostatic. Is it realistic to remember every antibiotic that's bactericidal? No, I would remember just some of the common ones. Cephalosporins and penicillin, while they're beta-lactam, they destroy the cell wall, so they're bactericidal. Aminoglycosides, fluoroquinolones, we're going to talk about shortly. Vancomycin, we just finished talking about. That damages the cell wall, so it's bactericidal. If we move to the other side, bacteriostatic, we're going to talk about some of the other ones that work in different ways to inhibit the growth of the bacteria. Clindamycin, erythromycin, sulfa antibiotics, tetracyclines. So just remember that there are antibiotics that don't affect the cell membrane or cell wall, but they can still be bactericidal. And aminoglycosides, fluoroquinolones, metronidazole are perfect examples of those, and we will talk about them. Okay? Okay, so tetracycline is the next prototype antibiotic. And in the same group, of tetracycline is doxycycline and minocycline, and they're all tetracyclines, but the prototype antibiotic is tetracycline. So tetracycline is used commonly, especially if someone has a penicillin allergy, and you just can't use penicillin. Then we have to use a different antibiotic, and sometimes we'll use tetracycline, the tetracycline group, as an alternative. And other times we'll use the erythromycin or the macrolide group that we haven't spoken about yet as an alternative to penicillin. So what can we use tetracycline for? Well, this group is definitely used for acne um, in all age groups, really. So it can be very effective for acne because part of the um, the problem with acne is that there's a bacteria that is leading to a lot of inflammation, pustules, and a lot of the skin effects are due to this little bacteria. So definitely the tetracycline group is the most common group for acne. Dental infections, so someone comes in with a dental abscess or a dental infection, we often use penicillin, but if we can't, then we can use tetracycline as an alternative. Sexually transmitted diseases. So chlamydia is a sexually transmitted disease. In males, it typically causes a clear, sticky mucus discharge from the penis. In females, it often causes some clear vaginal discharge. And the tetracycline group is effective in treating um, chlamydia. Some of the pneumonias are very effectively treated by tetracycline. So mycoplasma is just a type of pneumonia, and it's very sensitive to tetracycline. And as you'll see later, peptic ulcers are treated. So stomach ulcers or duodenal ulcers are treated with a combination of antacids and an antibiotic, and tetracycline is often in the treatment algorithms to resolve a peptic ulcer. And Lyme disease, if you see someone being treated for Lyme disease, there's a good chance that one of the tetracyclines is being used to treat it, since the bacteria is sensitive to tetracycline. So these are considered broad spectrum antibiotics. You can see that they cover many indications, which usually indicates that they cover an assortment of different bacteria. And they prevent protein synthesis in the bacteria. Okay, so adverse effects. Definitely some gastrointestinal upset from tetracyclines. Not as much as a next group that we're going to talk about, which is going to be the macrolides, such as erythromycin. They can definitely cause a lot of GI upset, but tetracyclines can still definitely upset your stomach. They can discolor the teeth of children under the age of 8. So we really try to avoid using tetracyclines under for children under the age of 8. The next common adverse effect is photosensitivity. So you get a dose of tetracycline, or you're on tetracycline, you go out in the sun, and you get a photosensitive rash. And this is not uncommon for any of these tetracyclines, doxycycline, minocycline, a photosensitive rash. And we will warn people, avoid being out in the sunlight while you're on this antibiotic, or avoid significant sunlight while you're on this antibiotic. And then, of course, super infections, that goes for any antibiotic. So what are the contraindications? Well, pregnancy, partly because you're going to affect the teeth of the developing fetus and stain them. And then the other one that's common is avoiding it in less than 8 years of age. So under nursing care, we've mentioned that to avoid sexual contact until the dosing is complete, if it's being used to treat chlamydia. Um, so I'm going to just give you a very common scenario. Someone comes in, they have, say, penile discharge. We think it's chlamydia, but we're not sure, and we culture the discharge. We send it off, but we want to treat them now. But we're not totally sure if it's gonorrhea or if it's chlamydia. Okay, so here's how we would treat this. We would give them an intramuscular injection of ceftriaxone that covers gonorrhea. And then we would give them, we have the choice of giving them a number of antibiotics, but one of them that's commonly given is 7 to 10 days of doxycycline, which clears the chlamydia. So there's an example where a tetracycline is used for an STD. Anyways, just to finish the course of the antibiotic prior to any sexual contact, and also advising your sexual partner to go and get treated. Otherwise, the patient is just going to get reinfected over and over. Avoiding lying down after administration. These antibiotics need to get into the stomach. If they stick in the esophagus, or if they haven't quite cleared the esophagus, they can really irritate the esophagus. So making sure that they are administered not necessarily right at bedtime when you're going to lie down, since they may not clear the esophagus. Considering taking a second contraception due to this potential effect on the birth control pill, that's basically been debunked, that adding another form of contraception. We used to tell patients that all the time. I think if you saw it on a test, it's still reasonable to answer that considering taking a second form of contraception is reasonable. Taking this antibiotic on an empty stomach, for sure. So tetracyclines are affected by food and definitely dairy products. So taking it on an empty stomach is the best way for it to get absorbed. So just to add a bit more detail to how you take tetracyclines, really telling the patient not to take this with any kind of dairy product or any kind of antacid is a very good idea, because those really impact the absorption of the tetracycline. Okay, so this next slide is just again reminding you that tetracyclines really can't be taken with any milk products, calcium, which is often part of an antacid, iron supplements, laxatives, and really it's good to remember this, because this really does have an effect on the absorption of any of those tetracyclines. So trying to take it on an empty stomach, unless it's really impossible due to gastrointestinal side effects. This image is showing you the discoloration that can occur in teeth if taken at a too young of age. It used to be that we would avoid tetracycline at the age of 12, but now that's been dropped to the age of 8. And it's really quite safe to use after the age of 8 in terms of the dental staining it causes. Okay, so let's talk about the erythromycin group. In this particular group, there's a couple that are very commonly used. So erythromycin has been used for decades. The problem with erythromycin, it is really tough on the stomach. It gives abdominal cramps, diarrhea, nausea, really hard to take. But it was a very good alternative in patients that had a penicillin allergy because it covered very similar bacteria. Just unfortunately, the side effects made it difficult for patients to tolerate. So other macrolides came out, such as azithromycin. And maybe some of you have heard of azithromycin or Z-Pak, and clarithromycin, which is another one in the same group, um, which are macrolides. So these are good alternatives for bacterial infections in patients that cannot take penicillin. And that's not to say that they're not effective as a first-line antibiotic as well. I'm just reminding you that if penicillin was the first choice, then often we'll use a macrolide if they're allergic to the penicillin. So pneumonias are commonly treated with azithromycin or the erythromycin group. Strep throat can be treated with this group. So a patient that comes in with strep throat, they can't swallow well, they have a lot of pain, their strep swab comes back positive. We can treat with either a penicillin, or if they're allergic to penicillin, with an erythromycin. Sexually transmitted diseases, another common use for this particular group. In fact, chlamydia is very sensitive to azithromycin, and it can be given as a one dose. So you get a large dose of it all at once, and that treats the chlamydia. So you don't need to take a week of azithromycin. Just one dose will treat chlamydia. How do they work? Well, they inhibit protein synthesis in bacteria. They're bacteriostatic. What are the adverse effects? Well, this particular GI upset is definitely very important because that is the main side effect of this group. It can any of these can prolong the QT interval. So when combined with other medications that can also prolong the QT interval, and we'll talk more about this. So it's typically, the problem is usually multiple drugs that are having an impact on the QT interval in the conduction system of the heart, and that's where patients can get into trouble with arrhythmias. Erythromycins can be autotoxic in high doses. That's not a common adverse effect. The next one is a good one to remember, that erythromycins don't get along with many other medications. Lots of interactions. And it's partly to do with the metabolism of erythromycin. It's metabolized in the liver, and it uses a lot of the same enzymes that other drugs that you use for their metabolism. So erythromycin can really make a mess of other medications and alter the drug levels. And a perfect example is warfarin. So erythromycin can really elevate the levels of warfarin, which is a strong blood thinner. So we try to avoid this group when we see that they're on other medications that can either prolong the QT interval, or in the case of warfarin, it can really elevate the level of warfarin. So contraindications, well, liver disease, because that's where it's metabolized. If it's noticed that the QT interval is already prolonged, we would not add an erythromycin. And if we notice that they're on medications that already prolong the QT, we definitely wouldn't add erythromycin. In fact, if we prescribed it in that scenario, I would really hope that the pharmacist would call and say, maybe consider using another antibiotic because of the other drugs that they're taking. So under nursing considerations, someone who's taking warfarin, as I just mentioned before, erythromycin will make a mess of the dose of the drug levels of warfarin in the blood. So monitoring the INR, which is how we monitor the how thin the blood is from the warfarin effects, we would monitor that if they had to be on erythromycin, since that is what's going to become abnormal. The INR is going to increase, meaning the blood is getting thinner and thinner and thinner. Usually we like to see an INR for most patients that are taking it for different conditions between 2 and 3. But when on an antibiotic such as erythromycin, the INR can become tremendously elevated, making the blood extremely thin and putting the patient at very high risk of bleeding. Taking erythromycin with meals, very good idea to see if you can tolerate the erythromycin. It's recommended to take with a meal. Avoiding use of this antibiotic with other drugs that prolong the QT interval we've spoken about, since once the QT interval gets to a dangerous level, the patient is at high risk of abnormal cardiac rhythms and even potentially death because of those rhythms. Okay, so I just want to clarify something on the slide uh, uh, that we just finished. Taking erythromycin on an empty stomach. So it's definitely best absorbed on an empty stomach, but it's so difficult to tolerate the medication that often people need to take it with a small meal. So the recommendation would be, sure, try and take it on an empty stomach, but often people need to go and take it with a small meal in order to tolerate it. So this slide, I think we've spoken about this a number of times, but you're going to hear it over and over again, so better to hear it multiple times. So many drugs. There's no way of memorizing all the drugs that prolong the QT interval on the ECG. And we're showing you that interval there between the Q wave and the end of the T wave. And hundreds of drugs will affect this interval. We tend to know the common ones, and it really helps to know the common ones because then it will avoid errors in terms of giving another medication that can prolong the QT interval. So often this is caught at the pharmacy level, or the prescriber is aware that the patient is on multiple medications that prolong the QT, so that adding a certain antibiotic such as erythromycin would not be indicated. So good idea to know some of the common ones. And I think I've mentioned in a previous PowerPoint that why do we care that we're prolonging the QT interval? Well, you can see as the QT interval gets prolonged, the next beat is going to land on that T wave, since the sinus node is an automated, it's like an automated pacemaker. It just keeps on sending out a new beat. So the next beat and the QRS can land on the T wave, and that's called a Q on T phenomenon, and that can be very dangerous because the T wave is when the heart or the ventricles are repolarizing, and when when the ventricles are repolarizing, they're in a sensitive state, and if they get hit with a QRS, so a depolarization, it can cause the ventricles to go into a dangerous rhythm called ventricular tachycardia. And in this particular case, it's a ventricular tachycardia called torsade de pointe. And it's just really how the ventricular tachycardia looks on an ECG that we call it torsade de pointe. So since we're still talking about, we're off the erythromycin, but I just want to remind you that, erythromycin is just one of hundreds of different drugs that can prolong the QT. And in the book, I'm looking at erythromycin causing interactions with all kinds of other drugs, which really it's impossible to remember every drug that erythromycin, for example, can interact with. That's what books and the internet are for. But it is good to remember that erythromycin is an antibiotic that often doesn't get along with other commonly used drugs. You don't necessarily need to know the whole list of what those drugs are. Just knowing when you see erythromycin, oh, that is an antibiotic that can cause a lot of drug interactions. Okay, and so this slide's just showing you prolongation of the QT, and often it's caused from drugs. Some people are actually born with a congenital prolongation of their QT, and they're at risk for ventricular tachycardia. So it's not only just drugs, but the ones that are caused by healthcare professionals, um, hospitals and clinics, are the prescribing of medications that prolong the QT. Okay, and so here's what torsade de pointe looks like, and really this is just for your so you understand it a bit. If you look at the waves going up and down, they're not even. Some of them are smaller, some of them are taller, and then they become small again. So torsade de pointe is really what's called, that's a French term of turning around a point. So when it's getting tall, it's getting small, it's getting tall again. So this particular ventricular tachycardia is turning around a point. It's getting small and tall and then small again. So it's very classic when you see it on an ECG. Some ventricular tachycardias have the exact same QRS appearance over and over and over again. So the waves look identical. Okay, and that's the more common ventricular tachycardia. Whereas twisting of points, which is the French here, torsade de pointe, getting small and tall and small and tall, is really classic um, for this type of ventricular tachycardia. And the reason we care is that we use a different treatment. For torsade de pointe, we use intravenous magnesium as the treatment to reverse this. I know that sounds very strange, but that is the #1 treatment to reverse torsade de pointe. Or the other treatment is actually to uh, cardiovert them, and that's using electricity to reset the heart and try to put them back into normal sinus rhythm. Okay, so let's talk about some aminoglycosides. These are really can only be given intramuscular or intravenous. They do not get absorbed by the gastrointestinal tract. One other drug that we spoke about not long ago was vancomycin, and vancomycin can be given IV or oral, but if it's given oral, it doesn't make it into the bloodstream. And aminoglycosides would be in the same category, that they just don't get absorbed by the gastrointestinal tract. So by far we use them intramuscular or intravenously, and they're very effective for gram-negative bacteria. And what are some common gram-negative bacteria? It's typically E. coli, another one called Klebsiella. There's a few other ones called Proteus or Pseudomonas. Those are gram-negative bacteria that are sensitive to gentamicin. So because gram-negative bacteria can be found in severe urinary infections such as pyelonephritis, um, in intra-abdominal infections such as diverticulitis, peritonitis, um, an infected gallbladder, which is called cholecystitis. The aminoglycosides can be used for those infections, and it's typically in sick people that need IV antibiotics, not patients that are going home, since they'd be going home with an IV. And also, gentamicin comes in eye drops to treat bacterial conjunctivitis. It also comes, there's a few that come in an oral form, and we'll talk about those in a moment. They don't get absorbed by the gastrointestinal tract. Okay, so what's the action? Bactericidal, okay, and how do they work? They disrupt protein synthesis. Aminoglycosides are very hard on the kidneys and the ears. So when giving these, we keep a close eye on kidney function tests, and we do peak and trough levels. We've actually gone away from aminoglycosides over the past 10 to 15 years because there's other antibiotics we can use that are effective and not as toxic as the aminoglycosides, but they're still certainly used. So remember, they're going to hit the kidneys hard, and they're going to potentially harm the hearing or lead to tinnitus, which is that ringing in the ear, in patients that are receiving this, and they become toxic. So we would definitely try to avoid aminoglycosides in pregnancy and in anyone with renal failure, because it's going to hit the kidneys even harder. As mentioned, it's typically an IV drug. It can be given IM as well, but definitely more common intravenously in the hospital. We do monitor, we ask patients, do you have any hearing loss? Can you hear me? And do you have ringing in your ears? Okay, because that is a sign of toxicity. But we also do peak and trough levels of the drug after the third dose of the aminoglycoside, whether it's gentamicin, tobramycin. Both of those are common IV aminoglycosides. And we can adjust the dose of the drug when we get the peak and trough levels back, so that we stay in the therapeutic window. Now, there's some other ones that are listed up there: streptomycin, neomycin. So neomycin is an oral aminoglycoside. So if we wanted to treat some bacterial colonization or infection in the gastrointestinal tract, we could use neomycin. And this can be used to suppress or to reduce the bacterial content in the bowel prior to, say, gastrointestinal surgery. Streptomycin is an antibiotic that's used for tuberculosis. So That is not a mainstream aminoglycoside that we would use for typical bacterial infections. And the other one, paromomycin, that's used for intestinal parasites. Uh, Again, not absorbed from the gastrointestinal system, so it can be used to treat intestinal parasites and not have any concern of it getting into the bloodstream, the antibiotic that is. So the main ones for bacterial infections intravenously would be tobramycin and gentamicin. Neomycin is oral, streptomycin is for tuberculosis, and paromomycin is for parasitic intestinal infections. Okay, just infections in general, and we're going to talk about sites of origin. So the concept of community acquired infections or community acquired pneumonia, as you see in brackets there, which is one that we'll end up talking about. So this is an infection that's acquired by a patient that hasn't recently been hospitalized or had any medical procedure that brought them to a hospital. So it's an infection that was acquired in the community. So we typically use the term for pneumonias, so community acquired pneumonia, CAP. We may use it for MRSA, community acquired MRSA, which tends to be much more treatable than hospital acquired MRSA, which is even more difficult to treat. So what we like to do is distinguish, where did you get the infection? Was it out in the community, which is by far the most common, or did you get the infection while you were in a hospital? And the main reason why we want to know this is hospital-acquired infections can be much more difficult to treat. They tend to have a much higher level of resistance to antibiotics compared to community-acquired infections. So it's important for us to distinguish where the patient was when they acquired the infection. Okay, so the next one is healthcare associated infections. So this is an infection that was contracted in a hospital or in some kind of institutional setting. It used to be called, or it can still be called, nosocomial infection. So these infections you acquired secondary to being within the hospital. So it wasn't in your system, or you didn't come to the hospital with this infection. You got it because you were in the hospital. So, and as I mentioned before, the reason we want to distinguish is if you've acquired a bacteria during your hospital visit or stay, it's much more difficult to treat because of high drug resistance. The bacteria that are acquired and infect patients within the hospital tend to be much more drug resistant. And methicillin resistant Staph aureus is a common one that can be acquired in hospital compared to out of hospital. So community acquired MRSA, easier to treat than in hospital acquired MRSA. And there's the term nosocomial, which is really the same term as hospital acquired infections. So these are pictures of MRSA. They tend to be very pustular. So Staph aureus tends to make a lot of pus. So you can see that they can be large boils. They can be spread throughout a limb with pustules everywhere. And when we culture these, it's very common to get a report that this is a MRSA infection. So, in hospital sources of infection, you can see that there are many, many ways of getting an in-hospital infection. A patient on the left is receiving IV antibiotics um, for a bacterial infection. That patient can spread it to equipment, to staff, to the toilet, sinks, handles, that can easily be transmitted to another patient within the hospital. So that is really why cleaning is extremely important in the hospital. So the cleaning staff typically are responsible for making sure that equipment is sanitized. The staff in the hospital are responsible for hand washing, making sure that their clothes, if they become soiled, are changed. And in this era where hospital-acquired infections are very common, you'll see that the cleaning staff are constantly going around with antiseptic solutions, antibacterial solutions, cleaning all these surfaces to make sure that other patients aren't um, receiving a hospital-acquired infection. Okay, so which are very common hospital-acquired infections? Well, a urinary tract infection. Patients often get or need a, uh, a urinary catheter. So say they're bedbound, they're unable to get to the washroom, say after surgery, or they're obstructed, such as a male that's been lying in bed for a different illness, and they had prostate issues even prior to coming into hospital, and now they're unable to urinate. They may receive a urinary catheter. We're actually much more selective and careful in who gets a Foley catheter, because we know we put patients at risk for acquiring a urinary tract infection. So that is definitely one source uh, of, uh, of acquiring a hospital infection. And also making sure that the catheter has been inserted using sterile technique. Because if sterile technique hasn't been used, then there's a high chance of acquiring a urinary tract infection. Surgical wounds. So post-op wounds are prone to getting infected. So they need frequent dressing changes. They need to be treated carefully so that someone isn't exposing the wound to an infection while in hospital. Respiratory tract infections, you can just imagine on a typical floor, many people coughing, uh, whether they're coughing onto the door handle or coughing onto someone else. Uh, this is a common hospital-acquired infection. And when we're saying respiratory tract, we're really referring to a pneumonia, a hospital-acquired pneumonia. And then bacteremia can be secondary to a urinary infection that's now spilling over into the bloodstream, or a pneumonia that's spilling over into the bloodstream, or say from having an intravenous line in that's become infected now, and now bacteria is going into the bloodstream, causing bacteremia, which can then lead to sepsis, right? So bacteremia just means you have you have bacteria in your bloodstream that we've grown. Sepsis is the inflammatory response of having bacteria in the bloodstream. Okay, so common sources for hospital-acquired infections. So definitely the patient's own bacterial flora. So we all colonize bacteria, whether it's on our skin, in our mouth, in our gastrointestinal system. And if we have procedures on those sites, we can get infected with our own bacteria. So whether it's having an intravenous inserted, or whether it's having um, surgery, um, a surgical procedure where you get an infection from bacteria that was initially just colonizing your skin or your gastrointestinal tract. Invasive devices. So anything that's in the body is a risk for getting infected. So if you have an intravenous, if you have a central line, which is just an intravenous line that's that's been inserted to get to the central venous system. Medical personnel, nurses, doctors, other staff that are coming in contact with the patient may have infections on their hands, may have an infection that they've acquired elsewhere, and now transmit it to the patient. And just overall, the medical environments, like the hospital, is a place where sick people are staying, and sick people are often sick because of different infections. So all areas of the hospital are constantly trying to maintain cleanliness with cleaning staff, but it's not always possible to keep all areas and all surfaces clean at all times. So hospitals are a risky place for picking up bacterial infections. Okay, so what's the prevention? Well, throughout hospitals, you're going to see all over the place disinfectants. So disinfecting wipes that kill microorganisms, and these are used on all the. They're not used on patients. They're used on non-living objects, right? So all the handles, all the countertops, all the areas in the rooms, at the nursing station, they're constantly being disinfected. You know, antiseptic, to distinguish from disinfectant, is a solution that we use on living tissue, so on the patient. So it it typically inhibits the growth of microorganisms, doesn't necessarily kill them. So antiseptics, think of solutions that we use um, to cleanse, say, an area of the skin for a procedure. Disinfectants are for non-living objects. Okay, so this next slide on prevention, I won't spend a lot of time on this. Frequent hand washing. In fact, hospitals have people that their job is to go around the hospital in very high use areas like the emergency room, or on wards, to see how staff are cleaning their hands properly. Because it is a skill to properly clean your hands. It's not just a matter of putting a bit of soap on, giving a quick rub. There really is a bit of a skill to get into the habit of doing to make sure that your hands are clean and that you're not transmitting uh, infections. Immunizations, making sure that the staff is up to date with their immunizations that they require, and also inquiring to see if the patients need any immunizations. So say for example someone comes in for emphysema or COPD, um, they may benefit from a pneumonia uh, inoculum or a pneumonia immunization to prevent them from getting infections. Antiseptics that are sometimes used on for staff or on patients, disinfectants that the cleaning staff use all over the hospital, and just making sure that patients and staff are educated about how to prevent infections. Because sometimes we have to ask patients to make sure, since they're in an isolated room for some infectious disease, um, they need to also properly wash hands and avoid contact with other patients. Okay, let's talk about some modes of transmission. You'll also hear this in pathophysiology. Some common ways of transmitting the bacteria to a patient. So the first one would be being in direct contact with an infected or a colonized individual, whether it's the nurse or the doctor. Direct contact or direct patient care, and you're transmitting the infection to the patient. And this particular mode of transmission would include hands not being washed between residents, contaminated gloves, um, and contaminated medical instruments would be included. The next one, vector-borne, is usually referring to the transmission of an infection either by an animal or by an insect. So a good example of this would be something like West Nile virus uh, being transmitted by mosquitoes, or malaria being transmitted by mosquitoes. So airborne is another route of transmission, and usually uh, it's uh, it's caused by the particles floating in the air and the microorganisms staying suspended in the air and then being dispersed all over just by the small air currents that are occurring. So uh, patients are susceptible from a distance, such as across the room, in terms of airborne transmission. The next one, droplet. So droplet transmission is typically it usually involves larger droplets, and it typically comes from the respiratory tract with coughing, sneezing, potentially even suctioning, and these droplets don't typically go more than a meter or say 3 feet. And they enter the patient typically from inhalation into their mouth or into their lungs or through the nasal cavity. Now remember that some of these droplet transmitted uh, mode of transmission, they can land on surfaces, and then the droplets can remain alive on the surface for a period of time. So droplets can also be spread by direct contact. And lastly, the common vehicle transmission. This refers to a contaminated source. So whether it's the food or medication or intravenous fluids or equipment that's been shared by multiple patients, um, this can lead to an outbreak within uh, uh, the hospital or wherever it's happening, because a lot of patients or people are going to be involved in this particular mode of transmission, right? Especially if it's food or intravenous fluids or contaminated equipment. Okay, so other pharmacological considerations. So in infants, they can have relatively undeveloped kidneys and livers that can put them at risk for toxicity. And the other issue with infants and children is most drugs are weight-based. So we need to get their weight in kilograms usually and administer the medication based on their weight. So it often requires some mathematics to calculate exactly the dose, and that's where errors can happen in children commonly, calculating the dose, because we're just not used to having to do that as much in adults, where it's more fixed doses for many medication. Older patients with reduced metabolism in the liver and reduced kidney excretion because they have a weakening kidney and liver system are at risk for toxicity of drugs. Um, so, so small children, older adults, medications have to be sometimes adjusted to avoid toxicity. Pregnancy, uh, antibiotics, we always need to think about the fetus. And here are some examples of where an antibiotic can lead to certain conditions. So sulfonamides, we haven't spoken about them yet, but they're sulfa antibiotics. In the third trimester of pregnancy, sulfa can lead to hemolysis, which is red blood cell breakdown, which can lead to high levels of bilirubin in the infant. And high levels of bilirubin can lead to brain damage called kernicterus. Not very common, um, and it typically takes very, very high levels of bilirubin to cause any brain injury. But I think you need to remember that uh, using sulfa antibiotics in pregnancy is avoided, especially in the third trimester, because of kernicterus. Gentamicin, well, we've already spoken about aminoglycosides that lead to renal toxicity and ototoxicity. So hearing loss can occur if aminoglycosides are used in pregnancy. And tetracyclines, discoloration of the teeth that would occur um, in the fetus and in children less than 8. And lactation, we often need to look up medications since many drugs can get into breast milk and then get into the infant. So another consideration when prescribing or uh, giving a medication to a patient that's lactating. Okay, so a slide on anaphylaxis, and it never hurts to go over anaphylaxis because it comes up over and over again in the setting of medications, in the setting of how it's treated. So having a good understanding of anaphylaxis is really important. So anaphylaxis is a severe allergic reaction. It's a systemic reaction of the immune system that's going to cause widespread symptoms, some of them being very dangerous and life-threatening. So in the case of a medication, since we're in pharmacology, really any of these effects can occur, but let's go over some of the really common one. So the skin, you can get urticaria, which is hives, itching, and flushing. Now, that by itself is not anaphylaxis. That's an allergic skin reaction. You require another system to be involved in order to call it anaphylaxis. So it could be the cardiovascular system, where you have hypotension from all the histamine release that's occurring in anaphylaxis. Tachycardia, a fast heart rate, because the heart is trying to keep up with the low blood pressure. Or it could be an airway issue, where you have swollen lips, swollen tongue, or a swollen throat, which can be a real problem um, if you run into airway edema, and patients are now unable uh, to oxygenate. The respiratory system. So the histamine release can cause bronchospasm and bronchoconstriction, so narrowing of the airway, leading to shortness of breath, wheezing. Stridor comes from the upper throat. It usually comes from the larynx, so laryngeal edema in the airway. Stridor doesn't come from the lungs. Hoarseness doesn't come from the lungs. It also comes from the airway, where the vocal cords are. Pain with swallowing. Again, that's that's where uh, uh, the the pharynx is dividing and becoming the esophagus and the trachea. So that's where you're going to have pain with swallowing. So the respiratory system, think of shortness of breath, wheezing, coughing. Um, Next one would be the gastrointestinal system, and this tends to be a forgotten one. So uh, taking a medication, whether it's IV or oral, and now you have sudden onset of abdominal pain, vomiting in the setting of hives or urticaria. That can be an anaphylactic reaction. So typically it's a skin reaction plus one of the other important systems, such as airway, the respiratory system, the cardiovascular system. The other ones, such as central nervous system, tend to be a bit of a combination of cardiovascular um, and and the sympathetic system. So lightheadedness, loss of consciousness, confusion, that's because the blood pressure is low. Okay, so really that's a cardiovascular effect. The anxiety is because the sympathetic system is turning on because the blood pressure is low. So the brain is sensing all this adrenaline or epinephrine that's circulating through the bloodstream from the adrenal glands, and is getting anxious. Loss of bladder control would be very uncommon in anaphylaxis, so I wouldn't remember that as a very common effect of anaphylaxis. You can definitely get swelling of the conjunctiva um, of the eyes, not a very common effect of anaphylaxis. The runny nose is really just from all the histamine release, the vasodilation, and your nose is just running. Again, not a common nor a concerning effect of anaphylaxis. So anaphylaxis, think airway obstruction, um, respiratory issues such as wheezing and shortness of breath, and cardiovascular, low blood pressure, fast heart rate, and gastrointestinal in the setting of urticaria, so crampy abdominal pain and vomiting. And then we need to think, oh, okay, this person just got a drug, they now have hives, plus gastrointestinal system. That's anaphylaxis. And what's the number one treatment for anaphylaxis? Intramuscular epinephrine. And we can repeat the epinephrine many times if needed, 2, 3, 4 times if we need it, and sometimes if after repeated doses of intramuscular epinephrine isn't effective in terms of reversing the airway obstruction, sometimes the patient needs to be intubated to put a tube into their trachea and ventilate for them. Sometimes we have to go to intravenous epinephrine. So an intravenous drip of epinephrine that we can titrate upwards to bring their blood pressure into a normal range. So that's rarely done. It's usually intramuscular epinephrine first. Okay, so say we suspect someone is having anaphylaxis, and we don't always know at the beginning. So whether it's to a drug, since we're in pharmacology, or whether it's from an insect bite or a food that they've eaten, sometimes we just don't know at the beginning. They haven't presented with all the typical symptoms and signs. So the first thing that we always do is ABC, airway, breathing, and circulation. Assess the patient first, because that is what's going to matter. And then if we determine that it's anaphylaxis, then they're going to receive an intramuscular injection of epinephrine, not subcutaneous anymore. We don't use subcutaneous epinephrine since it was absorbed poorly. And typically it's 0.3 milligrams. So an EpiPen is 0.3 milligrams of epinephrine. And we range anywhere from 0.3 to 0.5 milligrams of epinephrine per dose. So I would ignore that calculation based on kilograms. That's more for children. So in adults, it's 0.3 to 0.5, and it can be repeated every 5 to 15 minutes as needed to help with their wheezing, shortness of breath, airway, the feeling of tightness in their airway, low blood pressure. All of these will be reversed by intramuscular epinephrine. Calling 911 for immediate transfer, for sure. Even after you've given the epinephrine, they still need to go to hospital. The epinephrine may wear off and they may need another dose of epinephrine. So lying patient flat, well, that's just so that you don't get them up and their blood pressure plummets. Raising the patient's legs, again, that's to increase blood return back to the heart. So you're raising the legs to drain the legs of blood to get it back into the systemic venous system. At the hospital, giving oxygen if they're hypoxic. Typically, if their O2 saturation is less than 95% is typically abnormal, but certainly less than 90% they would be receiving oxygen. Intravenous fluids to maintain blood pressure if they're hypotensive. What other medications can we be given to treat them, especially the symptoms, knowing that epinephrine is still number one? That was given way up in the algorithm. So we can give them some inhalers, such as albuterol, which is a beta-2 agonist, to open up their tight airways a bit. We can give them antihistamines, such as diphenhydramine. Often we give it IV or IM to help with the itching. And because they've had so much histamine release in the body, so we use an antihistamine. Sometimes we need to use medications that are called vasopressors because the patient is so vasodilated from all the histamine release from the anaphylactic reaction. We have drugs that can vasoconstrict to get their blood pressure back up. And epinephrine is a vasopressor, but sometimes we need to go to other vasopressors. Corticosteroids, so intravenous corticosteroids, such as methylprednisolone. An equivalent oral one would be prednisone. So what do these do? Well, these inhibit the immune system from overreacting. So sometimes we'll give them in anaphylaxis to suppress the immune system and what it's doing that's contributing to the severe reaction. Okay, and finally, if we've given repeated doses of intramuscular epinephrine, we sometimes have to revert to intravenous epinephrine and intubation because their airway is so swollen or they're having such difficulty breathing. But really, that's a last resort. We try not to do that, but sometimes we don't have a choice. Okay, we're getting there. There's only 10 slides left. So prophylaxis or preventative medicines, uh, in terms of antibiotics, we've mentioned this before. So prior to a surgery, sometimes antibiotics can be given, especially if there's potential for contamination during the surgery. So say, for example, patients are having a kidney stone removed from their ureter with a cystoscope that goes in through the urethra into the bladder, and they're having some procedure done to try and remove the stone that's blocked in their ureter. They sometimes get intravenous antibiotics to prevent an infection of the urinary system. So that's prophylaxis. Dental extraction in the setting of a heart murmur or a mechanical valve of the heart. They get prophylactic antibiotics to try and prevent infection seeding on to the damaged valve or the metal valve. Okay, this slide on antibiotic prophylaxis is just reinforcing the same concept of what prophylaxis is. There is no infection. You're trying to avoid an infection. And there's certain circumstances where it can be beneficial. And we spoke about dental procedures in the setting of someone with a damaged heart valve or a mechanical heart valve, or certain surgical procedures where there's a higher risk of having bacteria go into the bloodstream and causing bacteremia. I wouldn't want you to think that most surgical procedures get antibiotics prior to the procedure, because that would not be accurate. It would only be ones with high risk. So say, for example, someone has appendicitis and the appendix has partially perforated when they go in, or they think that it's so inflamed that there's a possibility some of the appendix has perforated, then that person or that patient would receive intravenous antibiotics to prevent an infection. So there's just certain circumstances where prophylaxis is a good idea. And I think I mentioned a dog bite in the past or a cat bite. They're so prone to infections that we'll often give 5 to 7 days of an antibiotic in the hopes of preventing an infection. And here's just some facts on just smart use of antibiotics. And this is becoming more and more mainstream, that antibiotics should not be used just because somebody has a cold or somebody has an infection that's likely viral. Because we're exposing them to the side effects of the antibiotic with no benefit of the antibiotic. So, firstly, antibiotics can definitely be life-saving. Patients with overwhelming sepsis benefit from early administration of antibiotics. In fact, in some centers, the timing of the antibiotic is looked at. How fast did the patient receive the antibiotic for their sepsis or their pneumonia? What else is on this slide? So antibiotics, as we mentioned, are only for bacterial infections. Some ear infections in children, especially over the age of 2, do not require antibiotics. So under the age of 2, children should receive an antibiotic. They're more prone to complications. Over the age of 2, more and more anti-inflammatories such as ibuprofen are being used to try and settle the ear infection, and we often give it 2 to 3 days uh, of an anti-inflammatory such as ibuprofen to see if that settles it by itself. And you might ask, well, an ear infection is bacterial. That's not the case though. Many ear infections can be viral. And we don't know when we look inside an ear and we see an infected eardrum, tympanic membrane. We don't know if it's viral or bacterial. And in the past, we used to just give everybody antibiotics. But we realized that this can cause a lot of side effects, and it's often appropriate to give a course of an anti-inflammatory for 2 or 3 days. And if that doesn't settle it, then to use an antibiotic. The vast majority of sore throats, pharyngitis, are viral. So that's why we culture the throat to see, is it growing Streptococcus A? And if it's growing Strep A, then we could use an antibiotic. But even then, more and more, the evidence is showing that antibiotics aren't really required even for strep throat. The studies show that all it really does is reduce the length of time that you have the strep throat by about half a day to 3/4 of a day. So not much benefit there. Now, for exam purposes, for NCLEX, would you use an antibiotic for a strep throat still? Sure. But in real life, we often will let it run its course. We'll talk to the patient and they can help decide. Would you like an antibiotic? This is likely what it's going to do. These are the side effects, and you'll likely get better without taking the antibiotic. And the complications of strep throat, such as rheumatic fever, which is damage to the heart valves and potential damage to the heart muscle, is very, very rare now. The strains of strep A in the throat have changed over the decades. And that also goes for glomerulonephritis, which is inflammation of the kidney post-streptococcal. So you can have a strep throat in the past, and it can lead to glomerulonephritis, inflammation of the kidney. And that is extremely uncommon. So because the strains have changed, antibiotics are even slowly disappearing for strep throat. As I said, for exam purposes and for your level of knowledge, strep throat would still be used. An antibiotic would still be used for strep throat. Green-colored mucus is not a sign that an antibiotic is needed. That's correct. The green mucus of sputum, so whether it's green or white, that's just your white blood cells within the mucus that's fighting the infection. So only under certain circumstances do we really care that someone has more sputum production and more of a cough. And that's typically someone with COPD or emphysema. But a run-of-the-mill healthy person with green-colored mucus does not mean that they need an antibiotic. And as we've spoken about, there's many risks to taking a chemical such as an antibiotic. There's many adverse effects. So we're being more and more careful in terms of prescribing antibiotics. Okay, so let's talk about bacterial resistance. So basically, this entire module, we've been talking about bacteria. We haven't really brought up viruses and parasites. It's really bacteria that we're most focused on in this module. And bacteria can acquire resistance to antibiotics. In fact, many bacteria can actually thrive easily despite antibiotics being in the system, because they've developed either enzymes or different proteins that can stop the antibiotic from being effective. And why did antibiotic resistance start in the first place? Overuse of antibiotics is by far one of the most common causes of acquired antibiotic resistance. So you give an antibiotic over, you can imagine the population, millions and millions of times, and then certain bacteria mutate and develop an enzyme or a protein that's protective to them, and the antibiotic is no longer effective. And that bacteria now grows, thrives, and causes infection in that particular patient and in other patients. And I think this slide really shows the development of antibiotic resistance very well. So in number one, you have a large number of bacteria, and very, very few of them are resistant to the antibiotic that's being used. The antibiotic is prescribed, and it kills off the vast majority of the bacteria, including the normal flora of your body in your gastrointestinal tract. And that's why antibiotics are so prone to causing nausea, vomiting, and diarrhea, because they're killing off your normal flora on top of trying to kill the infection that's occurring. So what's left in number two are resistant bacteria. They can thrive in the setting in the body with the antibiotic. And then even with continued use of the antibiotic, those particular bacteria thrive and grow and have now become resistant. And those particular bacteria that are resistant can even transfer their drug resistance to other bacteria, causing even a wider array of bacteria that are antibiotic resistant. So really proper use of antibiotics is key for patients so that they don't develop resistance in themselves, and as a population we don't develop antibiotic resistance to the antibiotics that we have. So let's have a look at the main causes of antibiotic resistance. So the first one, overprescribing of antibiotics, killing, which really is causing, it's killing off um, bacteria that are sensitive to the antibiotic, including bacteria in the patient that is normal bacteria, that's healthy bacteria, such as in the gastrointestinal tract, and then promoting the growth of the resistant bacteria. Patients not finishing off their treatment of antibiotics. So if a patient takes an antibiotic and they've been prescribed, say, for a week or 10 days, if they don't finish it, really what's happened is you've still killed off uh, healthy bacteria, but you've allowed the resistant bacteria to remain in high numbers and to flourish. And that's the reason why we tell people, make sure you finish your full prescription. Unless you have an adverse effect, then report back to us, and we can determine whether you need a different antibiotic or the adverse effect is harmful enough that this one needs to be stopped. Antibiotics are used in livestock. So you'll often see on milk and other products, antibiotic free. And the reason why antibiotics are used in animals is they tend to produce more milk, such as in cows. They tend to grow better they tend to grow more, such as in for production of meat. The problem is that by feeding animals antibiotics, we're actually creating resistance, bacteria resistance in those animals that can then be spread to other animals to have high resistant bacteria, and also over into humans as well. The next one is poor infection control in hospitals and clinics. So if you have poor infection control in terms of sanitation, the use of disinfectants, that can lead to antibiotic resistance. So resistant bacteria can be on counters, door handles, all over. And that's really how patients develop hospital-acquired infections. Lack of hygiene and poor sanitation, don't need to say too much there. Poor hygiene and poor sanitation is definitely going to lead to uh, overgrowth of bacteria, including resistant ones. And the other issue, again, a big one, lack of new antibiotics. A lot of drug companies um, that produce medications, antibiotics don't tend to be very high up their list in terms of what drugs they want to develop. Patients take antibiotics for a week at a time instead of many other conditions where they may take a medication for their lifetime. So in terms of financial gain, a pharmaceutical company would be in a better position to make more antihypertensives, more drugs for osteoarthritis, more drugs for chronic conditions such as Parkinson's disease or Alzheimer's disease. And that's not necessarily a bad thing. It's just what it means is antibiotics aren't being developed at a rapid rate to fight the infections that are emerging. So, and that's partly why we are seeing many um, antibiotic resistant bacteria, because we're just not getting many new antibiotics onto the market. Okay, so one of the ways to avoid resistant bacteria is to prevent them in the first place. And preventing an infection means you don't need to use more antibiotics. So immunizations are key. So childhood immunizations and boosters later in life to prevent the infection that requires an antibiotic is a very good way of preventing resistant strains. Proper hygiene, so proper hand care if you work in a hospital or a clinic. Um, Hygiene when you're doing a procedure such as a Foley catheter, which is done under aseptic conditions, right? You don't want to introduce a bacterial infection into someone's bladder if it's not done properly. So otherwise, they end up on antibiotics. Putting in an intravenous line, making sure the skin is very clean prior to putting in an intravenous. So all these procedures require proper cleaning first. Otherwise, the patient is more prone to acquiring a bacterial infection. Diagnosing and treating infection properly. So, as we've mentioned before, typically we try to culture the whether it's a wound or a urine infection or a blood infection. We take cultures first, and then we treat with antibiotics. When the culture and sensitivity report comes back, we may be able to narrow the antibiotic spectrum to that particular bacteria. Instead of using a broad spectrum antibiotic, we may be able to use a narrow spectrum antibiotic. Appropriate use of antibiotics, we've mentioned, prescribing for bacterial infections and not for the common cold or other very common viral infections that are just going to resolve on their own. Preventing transmission of the infection to other people. So proper infection controls and educating clients and coworkers. So on proper hand washing. So if we see someone with, say, impetigo, which is a skin infection that's very contagious from child to child, we're not going to send the child back to school immediately. We're going to treat the infection, whether it's with an antibacterial cream or an oral antibiotic. We're going to treat it so that they don't transmit it to other children in the classroom. Okay, so let's just spend a bit of time talking about Clostridium difficile. And most people acquire C. diff from the use of antibiotics. So antibiotics upset and destroy the normal flora in your gastrointestinal tract and can lead to overgrowth of Clostridium difficile. You're going to hear the word Clostridium many times because there's an assortment of different uh, infections that originate from this particular group of bacteria. So Clostridium difficile infection in this case, and a diarrheal illness, but there's also Clostridium tetani, which causes tetanus. There's Clostridium botulinum, which causes botulism. So Clostridium is not a friendly bacteria to humans. So C. diff contains spores that can survive the stomach acid. It can actually get into the large intestine. And then it's it's likely not causing too much trouble there because your normal flora is protective to the patient. But when given antibiotics, it allows the Clostridium difficile to become overgrown. And instead of just colonizing a bit, it's now becoming a full-blown infection, especially with the use of broad-spectrum antibiotics. And definitely the most notorious one is clindamycin. Uh, Even just hearing the word clindamycin makes me think of Clostridium difficile superinfection because it's very common with that antibiotic. And myself, when I'm prescribing, I'm very hesitant to prescribe clindamycin because it's it's the most common antibiotic that can lead to Clostridium difficile. Now, other antibiotics can do it for sure, but it's definitely number one. Okay, so C. difficile will then flourish in the colon. It will release toxins um, from the bacteria, which will then damage the colon mucosa. And this will lead to profuse diarrhea. It'll lead to intense inflammation in the colon. The colon wall will start to bleed, so you'll get bloody stools, incredible amounts of diarrhea, abdominal cramps. Uh, the patient could have electrolyte disturbances, dehydration. So it's a nasty infection. Now, about 80% of Clostridium difficile infections are caused by antibiotics. Sometimes someone can acquire Clostridium difficile and we just don't know where it came from. And that's because the spores can live on surfaces for many weeks. So, for example, in a hospital, you touch a surface, maybe you were just visiting. You touch a surface, you touch your mouth, and suddenly, days to weeks later, you have fevers, abdominal pain, diarrhea, or bloody diarrhea. So most of them are caused by antibiotics, but because the spores can live so long on fomites, which are just different door handles and surfaces, like non-living surfaces, uh, some people get Clostridium difficile just from having come in contact with the spores. And it's definitely the most common hospital-acquired or nosocomial infection. And it's because we use a lot of antibiotics in the hospital. So once you've smelled Clostridium difficile enteritis or diarrhea, you won't forget it. It has a very particular smell. Usually the patient will tell you that they were on antibiotics in the previous 30 days, and now they've developed this unending diarrhea, abdominal cramps, and that makes us highly suspicious of diarrhea. Clostridium difficile. And then we get stool cultures, and we grow out the toxin, the C. diff toxin. So when we get stool cultures actually for C. diff, we're not actually getting the bacteria. We're not growing the bacteria. We're looking actually for the toxin in this case. So the report will come back C. diff toxin positive. And sometimes when we see patients uh, where we're highly suspicious because they've been on antibiotics and now they have this horrendous diarrhea and abdominal cramping and fever after the use of an antibiotic, we'll just treat them empirically. So we'll collect the stool to send it to see if there's Clostridium difficile toxin in it, but we'll also treat them empirically with metronidazole or what's become first line now, oral vancomycin. Okay, so these supra-infections, so whether we're talking about Clostridium difficile or oral thrush, which is candidiasis, or a yeast vaginitis, uh, these occur because the antibiotics are just going to um, destroy the host flora, bacteria, which are normal and healthy, and also the bacterial infection that you're trying to treat. And the host flora, which is naturally there and producing nutrients, and they're actually required for normal colon function. When they're destroyed, they make space for pathological microorganisms and bacteria to become overgrown, such as Clostridium difficile. And that's why supra-infections develop, because you've killed off the normal healthy flora that was living there, whether it's in the mouth, the gastrointestinal tract, or the vagina. So what would be signs and symptoms? So for thrush, you typically have white spots in the mouth. It's candidiasis. Uh, when we look in the patient's mouth that has thrush, they have whitish spots all over. They have difficulty swallowing. It hurts to swallow. And you can actually get thrush all the way down into the esophagus, so they can describe painful swallowing because the thrush is not just in the mouth, it's even further down. In the terms of gastrointestinal superinfection, we've discussed that. It's usually profuse diarrhea that doesn't seem to want to stop. And the big offender here is Clostridium difficile. And these infections typically occur with antibiotics that are more broad spectrum because they're able to kill many, many different types of bacteria that live normally within your gastrointestinal tract, your mouth, the vagina. So when they're destroyed, it gives the opportunity for other bacteria or yeast to become overgrown. And this next slide is showing you images of different yeast infections, so candidiasis. The one on the left, so where do yeast and fungus love to live? They love to live in warm, moist parts of the body. So it's much more common in the summer months when there's sweat. But any two folds of skin that are constantly touching each other are prone to yeast and fungal infections. So under the breast, very common spot. In the diaper of a child, if you look at that image on the right, um, a red rash with little tiny spots that are called satellite lesions that are even a bit further away from the actual rash. That's classic for yeast dermatitis, yeast diaper dermatitis, sorry. If we look at this patient's bottom that's being turned, you can see the gloves at the top. That's from moisture. That's from being in a wet bed with urine or stool, and the yeast can easily grow in that moist environment. So this is very important because that rash, if not treated, well, better to prevent it actually by making sure patients aren't staying in a warm, moist fluid. But it also needs to be treated now because that's going to lead to skin breakdown, and then skin breakdown is going to lead to ulcers, and ulcers can become extremely deep on the bottom, called decubitus ulcers, especially if you're lying all day because you're sick. And decubitus ulcers will lead to deep wound infections and often lead to death, since they're extremely hard to treat. Okay, so welcome to the next module here, and we're going to start this module off by talking about the treatment of urinary tract infections. And we can't cover every antibiotic that's available for urinary tract infections, so we're going to cover some of the common ones. So a UTI is, there's different types of UTIs. There's a lower UTI, so a lower tract UTI, which is a bladder infection, which is cystitis, and an upper tract urinary tract infection, which is pyelonephritis, infection of the kidneys, and it's typically a bacterial infection of the kidneys. When we're talking about pyelonephritis or cystitis, we're really referring for the most part to bacterial infections. Now, is it possible to have tuberculosis cause pyelonephritis? Yes, it's possible. But by far most bladder infections or kidney infections are from a bacteria. Okay, so how do the bacteria get there? Well, they usually ascend from the urethra, and that is why females are at much higher risk for bacterial infections in their bladder than males, since there's a much shorter distance. Following that, if you acquire a bladder infection, which is usually symptoms of burning on urination, which is dysuria, or urinating frequently, which we call frequency. Those are very typical symptoms of a bladder infection. Dysuria, frequency, the urge to urinate despite having just gone to the washroom. Now, if the infection is able to ascend further and create a kidney infection, we call it pyelonephritis. And that's a significantly more serious urinary tract infection. So urinary tract infections are divided into lower urinary tract, which is cystitis, and upper urinary tract, which is pyelonephritis. So let's go to a prototype slide on trimethoprim sulfamethoxazole. The brand name is Bactrim. So this is considered a sulfa antibiotic. It's actually two antibiotics in one, and we call it a sulfa antibiotic due to the sulfamethoxazole component. This is a very common antibiotic for urinary tract infections, whether it's a simple cystitis or a pyelonephritis, so upper or lower urinary tract infections, plus many other infections around the body. Of course, always bacterial infections. So the action of this combination antibiotic makes it a bactericidal antibiotic, since both components inhibit different parts of folic acid metabolism and prevent bacterial division. So let's go to adverse effects now. The first one is a very serious rash that patients can rarely get, called Stevens-Johnson syndrome. I think we have a slide on this in an earlier module to see the severity of this hypersensitivity rash. The next one is Clostridium difficile diarrhea. And going forward, you can just assume that any antibiotic can cause Clostridium difficile diarrhea, and any antibiotic can cause oral thrush or yeast vaginitis, since all of those are types of supra-infections from any antibiotic. Next side effect or adverse effect of bone marrow suppression, again, an uncommon adverse effect to this medication. Unless somebody is taking this antibiotic for prolonged periods of time, where they can develop anemia, reduced white blood cell count, which is leukopenia, and thrombocytopenia, which is low platelets. So they would need to be monitored with a CBC if they were on it for prolonged periods of time. Crystals in the urine, or crystalluria, is a condition where if not taking this medication with large amounts of fluids or significant amounts of fluids, it can form crystals in the kidney and in the urine. And we'll come back to this under nursing considerations. And lastly, photosensitivity. Taking this particular antibiotic and then being out in the sun for prolonged periods of time can lead to a photosensitivity rash. In your study book, ATI, it does mention not to take this particular antibiotic if you have allergies to thiazide diuretics, sulfonylureas, which is for diuretic, oral hypoglycemic medications, or loop diuretics. I think you can follow this information, but just to know that we do use this antibiotic even if somebody does have an allergy to one of those medications, since we realize that the cross-reactivity is much less than we thought in the past. So it's reasonable still to follow this information, but just knowing that in practice now we do use this in an antibiotic, even when patients with those allergies. Under nursing considerations, I already mentioned the CBC to follow cell lines for anemia, thrombocytopenia, or leukopenia. Always remembering to obtain proper cultures prior to initiating antibiotic therapy. And in terms of advice to the patient, reporting any significant rashes, maintaining proper hydration to avoid crystal formation in the kidneys, and also to make sure that the antibiotic gets to the kidneys and to the bladder in the urine, and advice on avoiding significant sun exposure, and also wearing sunscreen to prevent that photosensitivity rash. There is a mention in the book about kernicterus, and this is a reason to avoid this antibiotic late in pregnancy, since it can lead to hemolysis in the newborn, which is breakdown of red blood cells leading to elevated bilirubin levels, which can affect a portion of the brain, leading to a central nervous system condition called kernicterus. Very, very uncommon. And lastly, hyperkalemia. So hyperkalemia can happen if this medication is combined with certain other medications. There's some antihypertensive medication groups where the trimethoprim component of this antibiotic in combination with an ACE inhibitor or an ARB I realize you haven't done that module yet, but just know that the combination of this antibiotic with other drugs can lead to hyperkalemia. And lastly, we'll just talk a bit about some interactions. So there's certain drugs, such as this one, that just don't get along with many other medications that are used. So this antibiotic can interact with other commonly used medications, such as warfarin, causing significant elevation of warfarin levels, which can then lead to uh, thinning of the blood and potential hemorrhaging in the gastrointestinal tract. So anyone who's on this antibiotic and also using warfarin will either avoid using the antibiotic or monitor their INR very closely. Taking this antibiotic is typically on an empty stomach. It's usually well tolerated that way, and always remembering to finish the entire course of the antibiotic. Okay, so let's review the next antibiotic called nitrofurantoin. And this particular antibiotic is used really only for urinary infections. So on one of the previous slides, I said that antibiotics usually have multiple indications for different infections around the body, and that is typically true. For nitrofurantoin, we only use it for urinary infections, and in fact only for cystitis, which is a bladder infection. The other way that we use it is for recurrent bladder infections. So we don't use this antibiotic for pyelonephritis or really any other infections around the body. So how does it work? It works by inhibiting DNA, which then causes the bacteria to stop dividing. So it's a bacteriostatic antibiotic. And typically we want bactericidal antibiotics for something like pyelonephritis, since it's a more serious infection of the kidney. What are the adverse effects of nitrofurantoin? Definitely the most common ones are the first three: anorexia, nausea, and vomiting. Some of the other ones are more serious, but not as common. So hypersensitivity reaction is where your body has an odd reaction to the antibiotic, where you get fever, chills. You can sometimes even get some lesions in your lungs by the combination of the antibiotic in your immune system. So this hypersensitivity, and it usually just goes away once you stop the antibiotic. Things go back to normal. Bone marrow suppression can occur. It's not common. If someone were to be on this antibiotic for a prolonged period of time for recurrent bladder infections, we would monitor their CBC for anemia, for lowering of their white blood cell, and for low platelets. And lastly, peripheral neuropathy. Patients can get tingling in their feet and their fingers. So we would recommend that they monitor for that if they were on it for a long time. Most people are just taking this for a brief period of time. Since it's renally excreted, someone with severe kidney disease, we would avoid this antibiotic, since not only will it build up to toxic levels in the bloodstream, it won't get to the bladder, where we really want this antibiotic to be to fight the bladder infection. This particular antibiotic, nitrofurantoin, is really quite safe in pregnancy. We tend to avoid it early in pregnancy in the first trimester, since there is a bit of a weak link to some congenital defects in the fetus, and also very late in the third trimester we tend to avoid it because it can cause hemolysis, which is breakdown of red blood cells leading to increased bilirubin levels, which we spoke about with trimethoprim sulfamethoxazole. So it can happen in this one as well. So it's a relatively safe antibiotic, pregnancy B. We avoid it with severe renal impairment, so that would be some nursing considerations. It can turn the urine a bit of a rusty brown color and potentially stain the teeth. Advising patients to avoid crushing or chewing or opening the capsule due to the staining of the teeth. And taking this medication with food or milk to avoid the gastrointestinal symptoms. Okay, so the next group of antibiotics that we're going to talk about are the fluoroquinolones. So you'll recognize some of these likely, or you've heard of them, such as ciprofloxacin, moxifloxacin, levofloxacin, and these work by inhibiting an enzyme that's needed for DNA replication. So they're very broad spectrum antibiotics. They're all bactericidal, so they destroy the bacteria. And they come in an assortment of routes. They can be used as eye drops for bacterial conjunctivitis. They come in pills, and they come in intravenous formulations as well. So this slide really is a reminder that one of a newer adverse effect that we've discovered are tendinitises. So whether it's tendinitis of the knee or Achilles tendinitis, which is likely the most common one, are caused by these fluoroquinolones. And tendinitis can lead to tendon rupture with these fluoroquinolones. So Achilles tendon rupture, which is a pretty significant adverse effect. It either needs surgical repair or for a prolonged period of immobilization in a cast. So pretty significant adverse effect to an antibiotic. And we'll talk more on the next slide. Okay, so let's talk about some fluoroquinolones, and the prototype will be ciprofloxacin, which is one of the first ones that came out about 25 to 30 years ago. And you can see the other ones under similar. They really do have similar actions and similar adverse effects. So I think if you know one of them, you have a good feel for the other ones as well. So the indications, well, we're in the urinary tract infection section, and ciprofloxacin is commonly used for lower and upper urinary tract infections, so cystitis or pyelonephritis. It can be used with pneumonias. It can be used with bacterial infectious diarrheas. It penetrates bone and joints very well. So bacterial infections such as osteomyelitis, which is an infection of the bone, or septic arthritis, an infection of the joint, can be treated with ciprofloxacin. And also anthrax, which is a bacterial infection typically from farming animals. You can be exposed to anthrax, or through biological warfare, which is so relatively uncommon bacterial infection to get. Its action is bactericidal by inhibiting an enzyme needed for DNA replication. The adverse effects, well, we see gastrointestinal discomfort sometimes. It's not a huge adverse effect. The concerning one is the tendinitises and the Achilles tendon rupture. So that's a significant and strange adverse effect to the fluoroquinolones, and one of the reasons why we actually use them less often now. Superinfections can occur with any antibiotic, whether it's thrush in the mouth, vaginal yeast infections, or Clostridium difficile. Any antibiotic can cause those. And finally, photosensitivity. The fluoroquinolones, in combination with being out in the sun a lot, can lead to a photosensitivity rash. So that's where covering up or wearing sunscreen can be effective to avoid a photosensitivity rash. They're contraindicated in patients less than 18 years of age due to some research that shows that fluoroquinolones get into the cartilage of developing bones and cartilage, so it's avoided in patients under the age of 18 years old. It's also avoided in the elderly because of central nervous system effects, in particular confusion in the elderly. Fluoroquinolones can really confuse older patients. So under nursing considerations, these are given orally or intravenously. They're renally dosed, meaning the weaker your kidneys are, the lower dosing we need to use, since they're excreted by the kidneys. Intravenously, they're given typically over the span of an hour. Patients are advised of the adverse effects of tendinopathy, photosensitivity rashes, and superinfections such as thrush or vaginitis. Ciprofloxacin and some of the other fluoroquinolones don't get along with other medications. In particular, warfarin and ciprofloxacin do not get along. It can cause very significant thinning of the blood and an elevated INR when you're on warfarin. And INR stands for International Normalized Ratio, which tells us how thin a patient's blood is when they're taking warfarin. Another medication is theophylline that can be affected when combined with ciprofloxacin, causing very high theophylline levels. Theophylline is usually used for severe asthma attacks or for COPD. So it has a very narrow therapeutic window, and it can lead to toxicity very easily if ciprofloxacin is added to a patient that's taking theophylline. We usually avoid taking ciprofloxacin with dairy products, antacids, or iron products because of reduced absorption of the ciprofloxacin or the other fluoroquinolones. I just want to mention a couple of points in your ATI book. Firstly, it mentions not to administer ciprofloxacin to children under the age of 18 due to the risk of Achilles tendon rupture. That's a bit inaccurate. We don't use ciprofloxacin in under the age of 18 due to the fact that it accumulates in cartilage during the research of this drug. It can cause Achilles tendon rupture at any age. And lastly, I just want to reiterate that use of these fluoroquinolones in the elderly population can come with a significant adverse effect of dizziness, confusion, and restlessness. So we really try to avoid these in the older population. Okay, so the next medication is actually not an antibiotic. It's a urinary analgesic. It's called phenazopyridine or pyridium, and it's very effective at relieving the symptoms of a bladder infection. The painful urination, the sensation of urgency can be relieved within hours of using this urinary analgesic. So it numbs the bladder wall and the urethra, so that when you urinate during a urine infection, it's not extremely painful. The adverse effects, they're pretty minimal, except they turn all bodily fluids, let's say, orange. So your tears will be orange and it'll stain your contact lenses. So it's always important to tell people not to wear contact lenses when they're taking this medication for a urinary infection. And often you just need to take it for a few days until the antibiotic can work. So this medication is used in combination with the antibiotic that's going to remove the bladder infection. And for a day or two, while it's very painful to urinate, phenazopyridine can be used. So it turns the urine this orange-red color. It's avoided in acute kidney injury or chronic kidney injury, um, which makes sense since it's not going to easily get to the bladder. It's relatively safe in pregnancy with really minimal adverse effects, except for the significant color change that people should really know about. Otherwise, they'll have a big surprise. Two other things just to mention, not necessarily related to phenazopyridine, but to urinary infections. So people often try cranberry juice to treat a bladder infection. That's not very effective. Cranberry juice can be used to try and prevent a bladder infection. And the way it does that is any juice with vitamin C in it. Vitamin C is ascorbic acid. It makes the urine acidic, and that makes it more difficult for bacteria to grow. So whether it's cranberry juice with vitamin C or apple juice with vitamin C, it's really the ascorbic acid in the juice that's making the urine acidic and preventing a urine infection. But you can't use cranberry juice to treat a urine infection. It really needs to be treated with an antibiotic to get rid of it. The other thing I wanted to mention was the use of probiotics when taking an antibiotic. You, you should really avoid taking a probiotic at the same time as an antibiotic. They should be administered hours apart, since the antibiotic can interfere with the probiotic effects. And many people take probiotics to prevent some of the supra-infections of antibiotic use, but it's definitely recommended to take these, to space them apart by at least 2 hours. So this will be a quick slide. This is just showing the color of your urine when you're on phenazopyridine or brand name pyridine. And remember, this is not to treat the infection. This is to treat the symptoms and the discomfort of the urinary tract infection. And the main thing to remember about it is, well, firstly, that it's very effective, and secondly, that it stains other body fluids, such as your tears, and to avoid wearing contact lenses. And to also tell the patient that it'll stain any clothes that it comes in contact with as well.
Okay, so let's look at clindamycin. So clindamycin is a pretty popular antibiotic. What do we use clindamycin for? Well, if you remember when we spoke about cephalosporins, such as cephalexin or cefazolin, we can use those for skin infections. If someone has a severe penicillin allergy, we tend not to use cephalosporins. So if someone has anaphylaxis to penicillin, because cephalosporins are kind of like a cousin to penicillin, we just stay away from them because of the cross-reactivity. Now, if someone just has a rash on penicillin, we don't have a problem using cephalosporins. Okay, so someone has a severe allergy to penicillin and they have a skin infection. Well, we could use clindamycin. Okay, so bacterial infections of the skin, including MRSA, so methicillin-resistant Staph aureus. So that's a bacterial infection that can be in your lung, It can be on your skin. In fact, MRSA is a skin infection that spreads from one person to another through contact. An example would be on a wrestling team where one person gets a MRSA skin infection, and then basically the whole team starts to acquire the skin infection. Okay. Um, how about a dental infection and you're severely allergic to penicillin? Well, we can use clindamycin, and dentists love to use clindamycin because it's effective at treating the bacteria in the throat, such as streptococcus, and they often don't see the complications of clindamycin in patients that now come to the hospital after having started clindamycin for their dental infection. Clindamycin can also be used for acne, and it comes, sometimes we'll give it as a pill, but often we'll give it as a cream, as an acne cream. Okay, and that can be very effective. Okay, so the action, well, I won't spend too much time talking about that, but it inhibits the synthesis of bacteria, so inhibits division of bacteria by binding to the ribosomes. So it basically puts the brakes on protein synthesis within bacteria. Okay. Adverse effects, very important. They're almost all going to be gastrointestinal. So nausea, vomiting, diarrhea. What kind of diarrhea? Well, this is the most common antibiotic to cause Clostridium difficile diarrhea. Okay. It's about 15 times more common to cause Clostridium difficile than penicillins. And that's why we're often not a fan of using clindamycin because of the risk of causing C. diff. Okay. It can also give you a metallic taste in your mouth. Okay, but the really big concern is Clostridium difficile because now we have to treat Clostridium difficile with oral vancomycin or oral metronidazole as a second choice. Okay. So typically, patients take this with a full glass of water to make sure it gets into the stomach. Why? Because if we're giving it as a tablet and it gets stuck in the esophagus, it can really irritate the esophagus. Okay, so we just give it with a full glass of water. Okay, so just in summary, where are you going to see clindamycin? Treatments for skin infections such as cellulitis, maybe abscesses, MRSA for sure, and dental infections. Okay.
Okay, so tuberculosis. It is a highly infectious disease, especially in very crowded conditions, such as homeless shelters, prisons, where many people are in close contact for prolonged periods of time. It typically isn't very infectious with infrequent contact with someone. So think of it in terms of very crowded conditions where it spreads from person to person, usually by coughing. As many as 20% of HIV and AIDS patients have tuberculosis, and that's partly due to their immunosuppression. So mycobacteria in general and tuberculosis more specifically can easily invade a patient's body when they're immunosuppressed. So very high rates in patients that are coming from highly populated countries, such as India, and in the homelessness as well. The main way of acquiring this infection is through the respiratory route, so sneezing, coughing, and having prolonged contact with that person that's infected. So the symptoms often present as a pneumonia, so weakness, ongoing cough, um, shortness of breath. And because it's often a chronic infection, patients are often losing weight and have loss of appetite as well. Okay, so this next slide gives a bit of information on tuberculosis as well. So it's typically transmitted through the air in infectious droplets with patients actively coughing. And we reviewed some of the symptoms of someone with tuberculosis, of fever, fatigue, weight loss, productive cough, and often they start coughing up blood as well with the infection, so hemoptysis. Patients with tuberculosis often can have night sweats with this chronic pneumonia. And on the right side of this slide, you'll see it's called a PPD test, which is a subcutaneous or intradermal infection of tuberculin antigen that we use to test patients for any contact with tuberculosis in the past. So an injection is put just under the skin, and then 48 to 72 hours later, it's read to see if it's a positive TB skin test. Now, the test that's read 48 to 72 hours later is measuring the amount of swelling, or what's called induration. It's not measuring the amount of erythema or redness. That's not the important part. It's the induration or swelling around the injection site that's most important. So this slide is on the TB skin test, which is also actually called a Mantoux test. And sometimes you'll just see it, the PPD, which is just the derivative of what's in it, so purified protein derivative, and it's injected intradermally. In a positive test, and we'll get to what a positive test refers to, signifies that there's been exposure to tuberculosis. It doesn't signify that the patient has active disease or latent disease, where they've just had contact with someone who's had tuberculosis. And once you've reacted positively to a TB skin test, you're always going to react in a positive way with induration to the injection. So if someone has a positive TB skin test, the next step will be a chest x-ray to see if they have any evidence of active tuberculosis. The other point to note about a chest x-ray is if someone has tested positive in the past to tuberculosis, another way to screen them for tuberculosis is just to go right to a chest x-ray and skip the TB skin test since they're already positive. And the results are usually read 2 to 3 days following the intradermal injection. Now, the bottom picture is showing a measurement of the induration, not the redness, of a TB skin test. And as we'll see in another slide, that the determining if somebody is positive for a TB skin test depends on their medical conditions and if they're immunosuppressed or not. So, for example, somebody who's taking steroids or is HIV positive or is considered immunosuppressed will accept less induration to call it a positive test because their immune system isn't as robust and they can't produce as much induration. So in those patients, we will still call it positive even when the induration is relatively small. And we'll get to a slide on that information. Okay, so this slide is just showing you what is determined to be a positive test, depending on whether you have certain conditions, and usually it's relating to degree of immunosuppression. So for example, if someone has HIV or they're a organ transplant recipient, then anything greater than 5 millimeters, which isn't very big, of induration is considered positive. You would need 10 millimeters of induration for the list that's on the slide there. And for anyone who has really no risk factors at all, it's now 15 millimeters of induration to be considered uh, positive for the TB skin test, which again doesn't mean that you have tuberculosis. It means that you've had contact or exposure to the mycobacterium. Okay, and these are just different ways of actually diagnosing tuberculosis. So remember, the tuberculin skin test is just showing whether or not you've had exposure. It does not tell us whether the patient has tuberculosis, just that you've had exposure to tuberculosis. So diagnosing tuberculosis can be with a chest x-ray, although it's difficult with a chest x-ray since many other conditions can show changes in the lungs that are similar to tuberculosis. So we would definitely screen someone with annual chest x-rays, depending on what employment they have, if they are already TB skin positive, since it would be useless to have repeated TB skin tests. Sputum cultures, if we're very suspicious, but they can take anywhere from weeks to months to come back, since remember, mycobacteria is a slow-growing bacteria. There's certain blood tests that can be utilized to try and diagnose TB earlier than waiting for a sputum culture. And finally, there's a new TB skin test that measures the immune response to tuberculosis in a patient's blood sample. So these are just typical ways. The most common in the past was sputum cultures and chest X-rays. So in this next slide, we're just going to talk about some concepts of pharmacotherapy for tuberculosis patients. So what's the goal of pharmacotherapy? Because it's going to be months of treatment, is to eliminate the mycobacteria from the patient, while also trying to avoid the emergence of resistant strains. So this would come up, for example, if a patient was non-compliant with their medication. Potential resistant strains of tuberculosis can develop since the patient isn't always consistently taking the medication. And there are definitely resistant strains of tuberculosis out there, and they require multiple medications at the same time to try and suppress the growth of the mycobacteria. Typically, treatment can last anywhere from months to years for active tuberculosis. And if you're just TB skin positive, you will likely be offered treatment for the fact that you've had exposure, but you don't have active disease. And that's typically around 9 months of one medication that will come to. You can see for multi-drug resistant tuberculosis, that's where up to 24 months of treatment comes in to try and destroy the mycobacteria in the patient's body. And typically for active tuberculosis, it's never a matter of taking one anti-tuberculosis medication. It's a minimum of two, and often it's three or four at the same time to try and suppress the bacterial activity. So there's definitely an increased incidence of multi-drug resistant tuberculosis around the world, especially in impoverished areas, very crowded areas around the world, uh, very overcrowded prisons and homeless shelters uh, are are perfect places for tuberculosis to flourish. Prophylactic therapy. This is where someone has active TB at home, and then close family contacts and family members uh, may receive prophylactic therapy to avoid developing active tuberculosis themselves, because some of those family members will become TB skin test positive. Okay, and finally, the big challenge with patients taking multiple drugs, especially when they have multiple side effects, is compliance, right? So adherence to the medication regimen is really important to not only clear the disease, but to avoid resistant strains from developing. Okay, so let's talk about a very commonly used drug for active tuberculosis, and even more commonly, it's used for a positive TB skin test, where someone has tested positive, they've had exposure in the past, and now they need approximately a 9-month course of isoniazid by itself, not with other medications. Whereas in active tuberculosis, you need multiple uh, antibacterial or anti-tuberculosis medications to treat it. How does it work? It destroys the mycobacterial cell wall. What are the adverse effects? And definitely the first two are very common. So you can develop a peripheral neuropathy, so tingling in your hands and feet because the peripheral nerves are being damaged, and hepatotoxicity. So it causes inflammation of the liver. And lastly, it can reduce sugar control in diabetics, but definitely the first two are the most common. So when would we avoid isoniazid? In someone who has significant liver disease, since it can cause a hepatitis. So under nursing considerations, so typically someone is taking isoniazid for at least 9 months uh, if they're TB skin test positive, and for active tuberculosis it can be up to 2 years. So they will need monitoring of their liver function in the form of liver function tests, serum liver function tests, and also advising them that if they become jaundiced, yellow sclera is most commonly seen, or they have right upper quadrant pain where the liver resides, then they should follow up. So a complete course of therapy is typically in the 6 to 9 month range for isoniazid. And just like any antibacterial, definitely this one or any of the other tuberculosis medications, adherence is very important to avoid getting resistant mycobacteria. Now this, for active tuberculosis, can be combined with other medications such as rifampin, and we'll talk about rifampin. But for just being TB positive, TB skin test positive, it's isoniazid in isolation. What's the treatment for the peripheral neuropathy secondary to isoniazid? It's called pyridoxine, which is just vitamin B6. It actually reverses the peripheral neuropathy. So really the concept here with isoniazid is if you're treating latent infection, which means you've tested TB positive on a skin test, it's a 9-month course of isoniazid um, to rid yourself of the latent infection. So it's not active at all. You actually don't have any symptoms. In terms of active infection, this is where it's often to have 3 or 4 combination medications to uh, to treat the active tuberculosis and to make sure that resistant forms of it don't appear by using 3 or even more commonly 4 medications. So the next one is rifampin, which is another anti-tuberculosis medication. It's an antibiotic. It can be used in other bacterial infections, but by far the most common reason for using rifampin would be tuberculosis. It blocks the RNA synthesis in the mycobacteria. The big adverse effect would be, again, hepatotoxicity with this. So checking serum liver function tests would be required since you're often on these medications for a long time. Rifampin will discolor body fluids. So we've already mentioned one other drug in this module that can cause discoloration of body fluids. Rifampin can also lead to that. And typically it'll be an orangey color of tears, of urine, or sweat. The change in color is not toxic though. It's not harmful to the patient. And again, completing the entire course of rifampin. So rifampin could be added, for example, to isoniazid or other anti-tuberculosis medications as a combination therapy for active tuberculosis. So how do we know if the patient with tuberculosis is improving from these medications? So if you just had latent TB, you won't know because they never had symptoms to begin with. But with active TB, they'll have reduced coughing, reduced hemoptysis, reduced night sweats, and also obtaining sputum cultures, which, as mentioned before, can take weeks to get back because of the slow growth of this mycobacteria. But obtaining 3 negative sputum cultures can take many months to occur, and that gives us confidence that the mycobacteria is being cleared from the body.